Health. Well, good morning, everybody. Thank you for joining us today. I'm Amanda Aguirre, President and CEO of the Regional Center for Border Health. And from our headquarters in the city of Somerton, it is with great pleasure that we welcome you to our annual Social Determinants of Health Forum in Yuma County. This year's theme is COVID-19, Social Determinants of Health, Impact on the Border. We would like to thank our main sponsors, the Arizona Biomedical Research Center at ABRC, NAU Center for Health Equity Research, the Arizona Telemedicine Program at U of A, and Regional Center for Border Health. With special thanks this morning to our Planning Committee Co-Chair, Dr. Robert Trotter. Thank you, Bob. And most of all, we thank you for joining us today. We have an outstanding number of panel participants that will address the challenges that our Yuma border community has faced during one of the worst pandemics we have experienced in this century. As well as we all mobilize our resources to mitigate the impact of COVID-19 and to stop the spread, we found ourselves with an enormous challenge of sustaining a strong social and healthcare infrastructure safety net for the families and communities devastated by COVID-19. And we thank you all to all the agencies that have been collaborating with all of the entities at state level, at the local level, at state and federal, to mitigate COVID-19. I would like to thank Dr. Sabat for co-moderating our general session this morning and being part of our planning committee. Dr. Michael Sabat is an Associate Vice President for Northern Arizona University and Campus Executive Officer for NAU Yuma Branch Campus. Mike, morning.
Morning.
No. Ahí están en el correo de la jurisdicción.
Mike, you're going to give us some logistics for this morning?
Yes, good morning. Thank you, Amanda. I'm sorry I didn't hear you clearly on that last line. Good morning. I wanted to welcome everyone as well and thank you for attending. This webinar or conference is yet another in a series we have held to address various aspects of the social determinants of health in the border region. Because all of our previous meetings have been held in person and not using virtual technology, I want to take a few moments to review some of the logistics and housekeeping issues for this morning's meeting. Among the things to remember, perhaps first and foremost, is there is a translation button in the toolbar at the bottom of your Zoom screen. It's actually not translation, it says interpretation. So that button will allow you to hear the conference sessions in either English or Spanish. Be sure to change the language to the one you want to hear as speakers present. Q&A sessions will be held during the panels. Some will be at the end of the panel, some may be at the end of each speaker's presentation. If only a single Q&A session is done at the end of panels, it will be done in English. You will be able to submit questions through the chat box. The links to the 3 panel sessions following this introductory plenary session can be found in the chat box. So you'll be able to go to the chat box in a few moments and find the link to the panel that you want to attend. There are brief biographical statements about the speakers and moderators, and they can be found on the conference registration page. Certificates of participation or continuing medical education, CME, will be provided to everyone through email. At the end of today's session, you'll be presented with an evaluation form. You can complete it at that time, or if you don't have time then, we'll email it to you. In any case, we hope you'll complete the evaluation as it helps us gain important feedback for revising what we do in the future. Lastly, the panel sessions will be recorded and the resulting videos will be available through the conference registration page in about a week. I think that about covers all of the housekeeping issues I can think of, unless you have something else you want to mention at this time, Amanda. Seeing that that's not the case, now I would like to welcome and introduce Dr. Robert Trotter from Northern Arizona University Center for Health Equity Research. Dr. Trotter is an Arizona Regents professor with expertise in cross-cultural healthcare intervention and prevention research, translational and population healthcare, evaluation technology, cultural competency research, social network and systems dynamics, and the applied use of ethnographic qualitative theory and methods as research tools for designing and testing prevention and intervention programs. He has also had a longstanding interest in cross-cultural bioethical principles, cross-cultural applicability of human subjects protections, and indigenous evaluation processes. Importantly, Dr. Trotter is one of the principals behind the development and delivery of these sessions on the social determinants of health in our region. Welcome, Dr. Trotter.
Mike, thank you. It's hard to recognize myself. I just think of myself as being licensed for cultural nosiness. Welcome to everybody. I'm Bob Trotter. As Mike said, I'm a medical anthropologist, and I'm very interested in the social determinants of health and their impact on the US-Mexico border. Amy, would you go to the next slide? Okay, this whole series, we have a 5 to 6 year track record in working with Yuma through the assistance of the Arizona Biomedical Research Center. And I know Dr. Waddell will talk about this in some detail in a minute, but we work with ABRC in terms of their research grant programs, in terms of the science education program, which this series is a part of. And there's also the ABRC cord blood program and biospecimen locator program. Go ahead to the next slide. As Mike said, we're working through the Center for Health Equity Research at NAU. And part of the CHER program is a research collaborative called the Southwest Health Equity Research Collaborative. And our overall goal with all of these initiatives is to increase basic biomedical, clinical, and behavioral research to promote health equity in diverse populations in the Southwest. Let's go to the next slide. I wanted to show you briefly some of the CHER and SHRC research initiatives. And you see this long list, and all of these projects are engaged with or impact Yuma and our cross-border partners. So we're looking forward to, we've had 5 years of fantastic collaboration with community partners in Yuma, and we're looking forward to continuing that. One of the things I wanted to tout is the report that Amanda and our other colleagues in Yuma put out in terms of research priorities for Yuma and the Rio Colorado, San Luis region. And Amy is going to put the citation for that very important report in the chat box so that you can access it, because it really, it's a community engaged endeavor that really encapsulates the need for research, health equity research on the border region. Okay, next slide. This is just a restatement of our primary strategy, and it's to strengthen health workforce in key areas, build strong partnerships and community engagement, and the Yuma partnership is absolutely stellar and an important model for community partnerships. And we're also trying to strengthen NAU's infrastructure and ability to engage in meaningful research. And this is a part of the process to translate results of research back to communities. Next slide. This is contact information. Please contact us. We want to continue our engagement. We want to expand our engagement, and we really appreciate all of the partnerships that we have going. And with that, I'll stop talking and turn it over to Dr. Waddell or Mike.
Thank you, Dr. Trotter. Now I would like to welcome and introduce Dr. Victor Waddell, Executive Director of the Arizona Biomedical Research Center, which importantly, very importantly, has provided support for this conference series. Dr. Waddell is also the director of the Arizona State Public Health Laboratory. As a laboratory director, he's responsible for overseeing the entire laboratory, including the chemistry, microbiology, newborn screening, bioemergency response, and chemical emergency response sections at the state laboratory. He has served as president of the Association of Public Health Laboratories and is currently president of the Clinical Laboratory Standards Institute. Dr. Waddell earned his doctorate in molecular biology and genetics at Queen's University in Belfast, Northern Ireland, where he also earned a Master's of Science in Environmental Sciences and a Bachelor of Science in Biological Sciences. He's published widely on issues related to both public health and molecular biology. Welcome, Dr. Waddell.
Okay, thank you, Mike. Good morning, everyone. Great to be here with you. I'll try to keep this brief because I know we're running a little bit behind time, but like I said, good to be with everyone here. I know everyone's had a tough last 15, 16 months with the pandemic situation. And as Dr. Trotter mentioned, even with the Arizona Biomedical Research Center, we've had our ongoing challenges over the past 15 months. As he mentioned on the slide earlier, we provide funding for biomedical research in Arizona. We also provide funding for other institutions, and as he mentioned, funding for activities like this through the research education with all the universities in Arizona. Our funding comes basically from lottery tax and tobacco tax, and that funding is around maybe $11 million per year that we have to provide for Arizona biomedical research. And as mentioned, we have a cord blood program, which is a public cord blood program where mothers can choose to donate their child's cord blood, and it's banked and then can be used for life-saving transplants and operations. And so we've used about 75 of those cord bloods since the inception of the program throughout the United States and the rest of the world to save lives. Certainly the last year has impacted ABRC with the challenges that all the researchers have had, and also the folks like yourselves being able to conduct their activities and continue forward with research and continue forward with these conferences that we do. We all hope for the day when we can meet face to face again, because it's certainly not the same with these virtual meetings. But we certainly look forward today to hearing some good discussion with all of the challenges and situations that everyone's had, specifically in the border region. We have also been in communication through our border health folks through this whole pandemic with our partners in Sonora, and tried to work with them when possible. There's been a lot of unique challenges that we all had to go through, and even here at the Public Health Lab, our challenges with supply chain issues, just to get enough supplies to be able to perform testing, all of those different things that we never thought we would encounter. And indeed, some of those things are still ongoing. And so we're working closely with the federal government to try to get more of those supplies, to try to work with the labs in the state to be able to provide a level of testing throughout this whole pandemic. We've also worked with our department to try to help distribute some vaccines and also the remdesivir and other drugs from the federal government during this pandemic. So certainly there's been a lot of challenges, and all of you out there, I want to thank you for all the work that you do for all the Arizonans. Keep it up and keep going. I think we're starting to see some light at the end of the tunnel now. And I'll finish up there and I'll turn it back to Mike.
Thank you, Dr. Waddell. As I turn the session over to Amanda again, Amanda, I thought you might help me here and mention to our Spanish speaking attendees that there is an interpretation button at the bottom of the Zoom window.
Con mucho gusto, Mike. Para las personas que nos acompañan, los compañeros de México, hay un botón donde pueden ustedes poner para poder tener la traducción del programa. Está en el Zoom donde se encuentra usted ahí. Lo puede aplastar y va a tener la traducción al español. Thank you. Gracias. Y bienvenidos. So now it's my honor to introduce the Honorable Senator Mark Kelly. Senator Mark Kelly is a retired United States Navy combat pilot, engineer, and a NASA astronaut. He lives in Tucson with his wife, former Congresswoman Gabby Giffords, which I had the pleasure to serve in the state legislature. Mark is the son of 2 police officers, and he attended public schools from elementary school through U.S. Merchant Marine Academy and the U.S. Naval Postgraduate School. As a naval aviator, he flew 39 combat missions in Operation Desert Storm. Mark was selected as an astronaut in 1996 and flew 4 missions aboard the Space Shuttle before retiring from NASA in 2011. On December the 2nd, Mark Kelly was sworn into the United States Senate to represent Arizona. So it's my pleasure to introduce the Honorable Senator Mark Kelly, and we'll hear his remarks.
Hello, everyone. This is Senator Mark Kelly. A special thank you to Amanda Aguirre and the Regional Center for Border Health for inviting me to speak with you today. I would also like to thank all the partners here who are committed to healthy border communities. The Arizona Biomedical Research Center, the Center of Health Equity Research, U of A, NAU, Arizona Western College, Arizona Telemedicine Program, Yuma Regional Medical Center, Yuma County, Yuma Center of Excellence in Desert Agriculture, and TGen. Thank you all for the heroic work you do to deliver health services in Arizona and at the border. Each of you have been on the front lines working to reduce health inequities. You were there before the pandemic, and you're there now, and you'll be there after the pandemic is over. I believe that the way to solve tough problems is by bringing people together. That is exactly what you are doing today. This pandemic exposed and increased the very inequities you have been fighting tirelessly to address. Your work at this moment has never been more important. And that is why I wanted to participate and say thank you. And to reiterate that we need you in this fight more than ever. The folks here know that the border region has some of the highest disparities in income, in education, and in access to healthcare in our country. It also has some of the highest rates of chronic disease in the world. These factors contributed to Yuma being one of the regions hit hardest by the pandemic, not only in Arizona, but in the country. Minority communities, especially at the border, have been disproportionately harmed by the pandemic with higher transmission, hospitalization, and death rates. Nearly a third of Arizona households have experienced food insecurity since COVID-19. a dramatic increase from the year prior to the pandemic. Latino households, households with children and households who experience a job disruption were more likely to face food insecurity. As recently as February, the unemployment rate in Yuma County was nearly twice that of the United States. Latinas have had the highest unemployment rate of any group since the pandemic began. In December, women represented 100% of the U.S. job losses. Latina women constituted nearly half of that. Arizona also has a shortage of primary care physicians. We rank 44th of 50 states in total active primary care docs. More than 3/4 of the population in Yuma, Santa Cruz, and Cochise counties live in primary care shortage areas. This is why we fought so hard for both rural health centers and community health centers to make sure they received federal funding and the support for testing and vaccine distribution. In the latest COVID-19 relief bill, I voted to help secure $135.4 million for 23 Arizona health centers, which included funding for those serving our border communities in our state. All of these factors, employment, food security or insecurity, economic inequality, and limited access to health care underscores the challenges that we face and the work we must continue to do. The resilience and leadership that the Regional Center for Border Health has displayed throughout the pandemic, it's exceptional. You fought and advocated for your communities to get the resources needed for staffing, for PPE, for testing, for contact tracing, and vaccine distribution. The creative and innovative solutions you have developed to serve your community are remarkable, and they're a model for the nation. So please know that I'm your partner in this. You have my support, my commitment to work alongside you to improve access to healthcare and to close health inequity gaps along the border. It's my honor to serve you and to represent Arizona in the United States Senate. Thank you for having me today.
Thank you, Senator Kelly. A pleasure, and thank you for your service to this country. So now we are going to go into Mike, any more logistics for our members that are joining us today, and as we go into our panel.
No, I think we're okay. It's a new experience for all of us, so I hope everyone can transition smoothly into the panel sessions. Again, the links to panel 1, panel 2, and panel 3 are in the chat. So take a look at the chat, find the panel you want to attend, and click on the link, and we'll see you there.
And we'll see you in a few minutes. Thank you all. Thank you, Mike. I need to change to my channel. Yeah.
Okay, so I have put the links to panel 2 and 3 in the chat, and panel 1 is going to be in this room. So if you'd like to attend panel 1, just go ahead and stay put. And again, panel 2 is education's response to the coronavirus pandemic in the U.S.-Mexico border region, lessons learned. And panel 3 is research updates and strategies. Francisca, I see you have your hand up. Would you like to ask a question? Francisca, I'm sorry. Alvarado?
You have to leave that.
And just a reminder, panel 1 is San Luis, Rio Colorado, Yuma County COVID impact on the border and the social determinants of health. Emma Torres, this is the main session, which is where we'll have panel 1. So you're already in the right spot if you want to view panel 1.
Good morning, everybody. Can you hear me?
Yes.
I'm Alex Bejarano, Director of Public Relations for the Regional Center for Border Health. It is my pleasure this morning to introduce Dr. Marco Antonio Wakamatsu, Director of the Public Health Sector from San Luis Rio Colorado, Sonora. He has a pre-recorded presentation that we're going to put on right now, and I would like to remind you that the full bios of everybody are on the website, and so I will be briefly reading the short bios. No, but for the Wakamatsu's presentation. Are they going to put it? Amy, can we start Mr. Wakamatsu's presentation?
Yes. Okay. Sorry. I thought you were going to read the introduction.
See, I did already.
All right. I'll just share my screen.
Muy buenos días. Soy el doctor Marco Antonio Ramírez Wakamatsu, jefe de la jurisdicción sanitaria número 6 de los servicios de salud de Sonora. Quiero, antes que nada, dar un agradecimiento al Consejo Binacional de Salud del Condado de Yuma y San Luis Río Colorado, a la señora Amanda Aguirre y al Centro Regional de Salud Fronteriza por la invitación para participar en este evento, en donde nos tocará platicar con ustedes acerca del impacto en la salud y las determinantes sociales en nuestra frontera de nuestras comunidades de Yuma y San Luis. Antes que nada, para ponernos un poquito en el contexto histórico, aunque todo el mundo pues ya tenemos toda la información respecto a lo que ha estado pasando con el COVID-19, me gustaría hacer una pequeña reseña. Sabemos todos cuándo inició, todas las informaciones que estuvimos
all of this information that we were
el desarrollo de esta pandemia a nivel mundial, cómo empezaron a aparecer y desarrollarse, cuando aparecieron los primeros casos, por ejemplo, aquí en México, en la Ciudad de México, y en nuestro caso particular en San Río Colorado, Sonora, en el mes de marzo del 2020, en una mujer que se dedicaba a ser conductora de un taxi en la línea fronteriza, fue la primera persona que se contagió.
Well, that was the first person who
No
became
tenemos la fuente
infected.
primaria de contagio, pero creemos con bastante certeza que ella se contagió con
And
alguien
bueno, we know
de los
that this
Estados
person
Unidos,
got
algún
infected
turista
with
o algún
probably a
trabajador
taxi
agrícola.
driver
Son las gentes que más movilizan en esa área donde ella se desempeña.
and
También
probably
cabe
got infected through
señalar
someone
y
that came from
destacar
the
que esta
US.
persona
I'd like to
fue de las
stress
primeras
that this
personas que
person was
vivieron
one of the
COVID
first
en
ones
nuestra comunidad.
who got infected
La
within
franja fronteriza
our
pues se han
community.
desarrollado muchos casos. Cada uno
Well,
de
many
nosotros tenemos
cases
nuestra
have developed in our
estadística
border area.
binacional, cuántos casos ha habido en cada lado. En
We
el caso de
have
Sonora,
a
bueno, hasta
count
la
of
fecha,
each side.
el corte del mes de mayo de este año, tenemos 73,425 casos en nuestro estado.
We had
Siendo
425
después
cases in
del
our
estado de
states.
Nuevo León, el estado fronterizo que más casos
The
ha
state of
presentado.
Nuevo León.
Comparativamente con los casos diagnosticados en los Estados Unidos, bueno, son mínimos, pero esto tiene que ver mucho con
Unfortunately,
la
there was a lot of
cuestión
echo
del
and it's very
número de
difficult
pruebas
for
y
the
detecciones que se
interpreter
están
to
realizando.
interpret.
En este caso, estos son los números que
Well,
tenemos
in this
en nuestro
case,
estado y en nuestra
these are the
ciudad.
numbers that we have.
En los municipios de Sonora
Within the Sonora
tenemos casos de
municipalities,
COVID
we have COVID cases.
en la incidencia registrada por semana
As far as
epidemiológica y
the
por
incidents
incidencia.
registered by
Si ustedes
week,
pueden darse cuenta,
and you can
bueno, los
see
estados fronterizos, las
that
comunidades
the border
fronterizas son las comunidades
areas are
que
the
más casos hemos
communities
tenido,
that have had
aunque
most
Hermosillo, pues,
cases,
como
although
capital del
Hermosillo
estado,
being the
Ciudad
capital,
Obregón,
and
Caborca,
Ciudad Obregón,
Cajeme,
Caborca, Cajeme,
San Luis Río Colorado,
San Luis
Nogales,
Río Colorado,
son las ciudades más
Nogales
grandes, son donde más
are the
número de
biggest
casos,
cities and
números
where
de
we've had the most
fallecimientos.
cases.
Igual, la mortalidad que se ha
Likewise,
estado presentando también
mortality
es muy importante hacer notar
numbers, well, are very
que
important
hemos estado
to cite.
presentando
We have
en
seen
Ciudad Obregón la mayor cantidad de
in
muertos,
Ciudad
después
Obregón
Caborca
the
con la gran
most
cantidad de
deaths,
muertos,
in Caborca as
comparativamente
well,
con la cantidad de gente que hay en Hermosillo, pues ha habido
considering the
muertes.
population in
Ustedes se
Hermosillo.
pueden dar cuenta en las comunidades en
You
las que
can
ha habido
realize that
más fallecimientos, son las comunidades que
where
se
we've had the
encuentran
most deaths,
en el área del corredor del
these are the
Pacífico,
communities
por donde pasa la carretera federal y el
where the federal roads go through. Unfortunately, the audio is not very good and it's very difficult to understand.
hacia allá. Entonces las rutas de migrantes también corren por esas partes y obviamente como se ha sido demostrado, entre
So
mayor,
as has been shown,
mayor número de casos y mayor número de defunciones.
we've had the
Estos son los
most
casos por semana epidemiológica en San Luis Río Colorado, Sonora.
in San Luis Río Colorado.
Esto viene desde el 2020,
Well, this
donde a partir
comes
de la semana 15, que fue aproximadamente
from the
en el mes de
15th
abril
week.
del 2020, empezamos a tener una elevación en el número de casos bastante importante.
We've had the most cases.
Aproximadamente en el mes de octubre, donde empezó a bajar el número de casos.
Unfortunately, the volume
Una meseta para luego volver a tener un rebrote aproximadamente.
is not working correctly, and the interpreter cannot interpret.
Fue en el mes de noviembre del 2020,
But we will try.
con casos hasta la
It
primera
was
semana de
November
enero,
2020
descender.
cases
En
beginning the
nuestra
first
Colorado,
week of January, and then it
una
went
etapa
down.
en que ha descendido bastante el número de casos.
So the number of cases has gone down,
Pero diario estamos
but daily
reportando
we are still reporting
personas enfermas y personas fallecidas.
people that are getting sick
Estos
and
son
that
los
are
casos
dying.
confirmados,
These
los casos
are
confirmados son
confirmed
aquellos a los que se le ha
cases
detectado la prueba confirmatoria a través de PCR
where
en su estado.
the PSR
Información
test has been given,
que hemos estado comentando hace unos momentos.
just as we mentioned a few
Son
moments ago.
en el registro actualizado con los 73,400
Well, this is
personas
the
confirmadas.
number that
Río
we've had,
Colorado,
over 73,000 people. In San Luis Rio Colorado, we are number 6
Ya,
as far as cases go.
Comentábamos Hermosillo, Cajeme, Nogales, Guaymas,
We have
Caborca,
Hermosillo, Cajeme,
Navojoa,
Guaymas, Caborca, Navojoa
hemos tenido más casos. En
are the places where the most cases
los
have
números de
been
defunciones, aquí las
seen.
cosas cambian un poco.
As far as
se encuentra
deaths,
en un empate con
the numbers
la de
change. We are tied with
Nogales, en el que tenemos
the
500
city of Nogales,
ambos, compartiendo el tercero y cuarto lugar.
sharing
Con Hermosillo y
third and
Cajeme, que
fourth
son las
place.
ciudades que tienen
Hermosillo,
el mayor
Cajeme
número de habitantes.
are the cities that have the most population.
¿Cuáles son los efectos directos que ha habido en la
What are
comunidad?
direct
Ha habido un
effects
aumento
over
en la
the community?
mortalidad, ha habido un aumento en el estrés
We've
de la
had an
comunidad,
increase
la
in
gente
mortality
se encuentra
and
más
stress.
angustiada, más tensa, más
People are more
molesta,
tense,
con síndromes
are
depresivos,
stressed out,
de
depressed,
ansiedad, y todo lo que conlleva el confinamiento
and
prolongado.
everything that
Problemas
confinement
económicos han
brings
aumentado
about.
con un cierre bastante numeroso de empresas, de negocios,
Many
de
businesses
y de la movilidad,
have closed,
movilización económica que siempre ha caracterizado
and
a la
the
frontera, la dinámica
financial
ha estado
situation
además de que tenemos
has
que
been very
recordar que
difficult
el
aside
cierre fronterizo ha impactado mucho en la economía de
from
ambos
the
lados.
impact over the
Hubo
economy
una
on both
saturación
sides.
hospitalaria muy marcada con muchas carencias que se presentaron durante los picos de la
We
pandemia del
saw
año pasado, habiendo
many
que
problems,
reestructurar el área
and we
hospitalaria
tried
para
to
reconstruir
restructure
espacios que normalmente eran
our
destinados para otro
hospitals.
tipo de enfermedades para
I'm
hacer
sorry, the interpreter cannot understand.
Afortunadamente, conforme se han ido disminuyendo los casos, hemos podido retornar a las áreas que antes se ocupaban, pero seguimos teniendo áreas exclusivas para COVID. En el sistema de salud, ha sido uno de los sectores que ha sido más fuertemente golpeado en este aspecto. Desde el desgaste físico por las guardias, por la cantidad tan intensa de trabajo, desde el momento en que han tenido que cuarentenarse junto con los enfermos y a veces no regresar a casa por el temor de contagiar a la gente, desde el hecho de tener ese desgaste, estar viendo a tantas personas enfermas,
Being seen so many people that are sick,
como deberíamos de pensar que deberíamos de proporcionar al 100%, en relación a que hubo carencias de insumos, de medicamentos. En San Luis Río Colorado, si ustedes recuerdan, no tenemos áreas de terapia intensiva, entonces tuvimos que habilitar áreas, traer refuerzos de gente de la capital del estado para que pudieran apoyarnos en este tema de la atención de los pacientes críticos con múltiples carencias. Hubo
we had
cierres de las áreas primarias de atención a la salud de la gente, se tuvo que hacer
close
atención por vía telefónica,
primary care centers. We had to assist through the telephone. We had great issues
también, como todos saben, todas las
with our health system.
Entrando al tema de las determinantes
Now,
y COVID-19 con su impacto
speaking of determinants and COVID-19,
hay que recordar la
the interpreter just cannot continue on.
Mundial de la Salud en relación a los determinantes sociales en salud son las circunstancias en las que las personas nacemos, crecemos, vivimos, trabajamos y envejecemos. Esto incluye al sistema de salud, que es el resultado de la distribución de los recursos que hay en el gobierno. El COVID-19 ha afectado a todo el mundo y nuestra frontera ha sufrido repercusiones debido a las características propias del entorno, con una problemática multifactorial propia de nuestra zona. Dentro de esta problemática tenemos que ver la cuestión de la equidad de los servicios de salud y podemos identificar varios tipos de vulnerabilidad que tienen nuestras poblaciones. Hay una vulnerabilidad clínica, una social y una epidemiológica. En el caso de la vulnerabilidad clínica, pues ahí tenemos que ver la edad. Sabemos perfectamente bien que nuestros adultos mayores de 60
we know that people that are over 60 years old
por su misma edad,
and continue being people that, because of their age and characteristics, are people that are in. It's very difficult to understand. I'm so sorry.
En el análisis que se ha hecho de las defunciones en general, se ha visto que más del 80 y 85% de las personas que murieron han tenido una o más enfermedades crónicas como hipertensión arterial, diabetes, alguna enfermedad crónica diversa, cáncer, inmunodeficiencias, etc. En el caso de la vulnerabilidad social, Tendremos que ver la situación económica, el nivel educativo, las situaciones y condiciones laborales, el estatus migratorio, el género y la diversidad sexual. Para todos es conocido que la afectación de las personas que tienen menor ingreso per cápita en el aspecto económico tienen más riesgos de tener más problemas y más complicaciones, ya que eso limita a veces su acceso a recibir un servicio de salud cuando no pertenecen a algún sistema de salud donde puedan recibir su atención. En el asunto del nivel educativo hemos tenido que luchar contra creencias firmemente arraigadas de la gente acerca del aislamiento, del uso del cubrebocas, del lavado de manos, de la aplicación de la vacuna, muchas cosas de esas que afectan de alguna manera las acciones de promoción y prevención de la enfermedad debido al nivel educativo de las personas. En el caso de las situaciones y condiciones laborales, bueno, hay muchos lugares en los que hay una gran cantidad de hacinamiento del personal, como son en las maquiladoras, en los campos agrícolas, en los que no hay manera de establecer de una manera continua los protocolos sanitarios que nos dicen el distanciamiento social y el uso del cubrebocas. Entonces, en las aglomeraciones que se hacen en las áreas donde van a salir a transporte de su casa a sus áreas de empleo, todas estas situaciones nos han en la sociedad ante este tipo de cosas. A pesar del COVID-19, las situaciones migratorias han estado fluyendo, siguen viniendo gentes de Centroamérica, de Sudamérica, buscando el famoso sueño americano. Llegan a esta comunidad, como no hay manera de pasar, se quedan aquí en San Luis un tiempo. Algunas de estas personas hemos detectado que vienen ya con el problema del COVID-19, lo dispersan en los lugares en los que están. Eso significa, son poblaciones que no son detectables a veces porque están en la clandestinidad y se mueven continuamente, favoreciendo la dispersión de este problema. En el caso de la vulnerabilidad epidemiológica, estamos hablando de la mayor exposición, del retraso en el diagnóstico y la dificultad para el aislamiento y la cuarentena. Esa gran movilización de la gente que no entendió en su momento la importancia del distanciamiento social en la contención de la enfermedad, nos hizo que tuviéramos toda esa gran cantidad de problemas que estuvimos teniendo para poder contenerla. En el caso del diagnóstico, pues hubo muchas limitantes a veces para poder hacer las pruebas confirmatorias. En el caso particular de nosotros, estamos practicando pruebas de PCR que son el estándar de oro para el diagnóstico de COVID-19. Sin embargo, todas nuestras muestras tienen que estar transportadas a la ciudad de Hermosillo, que es donde se procesa en el laboratorio estatal, que es el único certificado que tenemos. Eso habla de días para que lleguen, días para que nos den el resultado, que regrese nuevamente el resultado y entonces poder tomar las medidas epidemiológicas necesarias en cuanto al aislamiento y las indicaciones que se les dan a las personas, por supuesto, desde antes, desde que se tiene la sospecha, pero siempre el tener el retraso en el diagnóstico es muy importante. En el caso también, la gente era muy difícil, no entendían el concepto del aislamiento, no entendían el concepto de la cuarentena, de que tenían que quedarse en casa, de que habría que permanecer tantos días aislado si estuve en contacto con una persona enferma confirmada, tantos días en aislamiento si estuve diagnosticado y confirmado como un paciente. Eso forma parte de la cuestión cultural, de la cuestión educativa, de la idea preconcebida que tienen las personas acerca de la enfermedad y muchas veces del no pasa nada. ¿Cuáles son las recomendaciones? Debemos de identificar y analizar las situaciones de vulnerabilidad social y epidemiológica. Aquí es bien importante que todos trabajemos como comités binacionales, como autoridades de salud binacionales, buscando incidir nuevamente en los determinantes sociales, la vulnerabilidad de la sociedad en todos los aspectos que ya vimos, y en el aspecto epidemiológico para reforzar nuestro trabajo sanitario es sumamente importante. Debe haber una coordinación efectiva entre los agentes implicados, servicios de salud, los centros de atención primaria, los hospitales. Yo creo que es urgente que todos los actores que estuvimos involucrados en el manejo de la pandemia durante el año pasado en los picos más altos, nos reunamos ahorita en este momento en el que los casos están hacia la baja y todavía no tenemos un repunte, para que podamos analizar los eslabones críticos. ¿Qué pasó? ¿Qué nos faltó? ¿Qué podemos hacer mejor? ¿Qué hay que mejorar? ¿Cómo tenemos que coordinarnos entre todos? ¿Cómo podemos mejorar nuestras redes de atención hospitalaria? En el caso, por ejemplo, de San Luis Río Colorado, el Hospital General de San Luis fue el hospital de concentración de pacientes COVID. ¿Por qué? Porque aquí las otras instituciones como son el ISSSTE y el ISSSTESON, el municipio, no tienen un hospital que pudieran ser manejados. Solamente el Seguro Social pudo también reconvertirse su clínica hospital de aquí para poder atender pacientes porque tenían una gran cantidad de enfermos en su derecho a audiencia. La comunicación es una herramienta que tiene que tener las características de universalidad, ya que tenemos que estar proveyendo a la comunidad, a la gente, de una información oportuna, veraz, confiable, porque con las redes sociales existe una gran cantidad de desinformación acerca de lo que deben de hacer, de lo que sí se puede hacer, de lo que no se debe de hacer, y eso es importante que nosotros como autoridades de salud estemos mandando esos mensajes que sean acordes a lo que se está presentando y que pueda reforzar el conocimiento de nuestra comunidad. El reforzamiento de la capacidad del sistema de salud y las áreas de bienestar social son determinantes. Necesitamos que nuestros hospitales, ojalá que con este aprendizaje que hemos tenido, nuestras autoridades puedan visualizar nuevamente cuáles son las necesidades que se están teniendo ahorita actualizadas y que se puede invertir en que podamos tener una capacidad de respuesta más efectiva para lo que se vino y para lo que probablemente se pueda venir. Tenemos de tener una respuesta cercana al territorio. Nosotros, los ayuntamientos, los condados, las autoridades civiles, estatales y federales, debemos estar en coordinación para poder atacar conjuntamente esta situación. Hay mucha gente que están en situaciones de vulnerabilidad y que necesitan apoyo. Hay mucha gente que no tenía a veces ni despensas ni cosas que comer. Hay gente que tenía necesidades de medicamentos en su casa que no podía ni siquiera transportarse a los lugares para recibir el servicio. Ojalá que podamos entre todos fortalecer y establecer nuestras redes comunitarias locales, grupos profesionales asistenciales a través de Facebook, a través de las redes sociales o el teléfono, en el que la gente pueda atenderse y pueda obtener una consulta, una orientación. El aspecto de la cobertura sanitaria universal que se ha hablado mucho y que se ha buscado mucho, pues sería una respuesta que pudiera aliviar en mucho la necesidad de mucha gente que no tiene acceso a la salud pública porque no tiene ningún tipo de cobertura. Y como lo comentaba hace un momento, estas reuniones inmediatas intrasectoriales, o sea, hacia adentro del sector salud, entre todos los que manejamos problemas de salud, y luego intersectoriales, en donde puede estar educación, economía, turismo, Secretaría del Trabajo, todos los sectores que sea necesario que estén presentes para poder prepararnos para una probable, y ojalá que no se vuelva a presentar, pero por ejemplo, estamos viendo las fluctuaciones y hay otros países del mundo en el que están teniendo repuntes de la pandemia sumamente importantes. ¿Cómo podemos llevar esto a cabo? Bueno, desde las conferencias mundiales de promoción de la salud, se ha buscado por muchas maneras de que la promoción de la salud tiene que estar incluida en todas las políticas públicas. Debemos de hablar con los tomadores de decisiones, con las personas, con los funcionarios de gobierno, con las gentes que son electas a los puestos de elección popular. Debemos de concientizar y sensibilizar de que en todas partes debe haber promoción de la salud y prevención de enfermedades. Debemos de involucrar a toda la población. Hay segmentos de la población que no lo entienden, que no hacen caso, que tienen sus propias ideas preconcebidas acerca del tema. Entonces tenemos que involucrar a todo el mundo porque el problema es de todos y solamente entre todos lo vamos a poder solucionarlo. Centrarnos en las causas o los determinantes sociales de la salud, tratar de sacar adelante la marginación, mejorar los sistemas de transporte, el ingreso económico de la gente, etcétera. Insistir en la participación efectiva de la población y debemos de reorientar los servicios de salud para facilitar y apoyar la promoción de la salud. Sabemos de que tenemos que reforzar los hospitales, que son donde llegan los pacientes enfermos y complicados, pero al final del día, al principio, el primer eslabón siempre va a ser la promoción de la salud y la prevención de las enfermedades. Por ejemplo, hay algunos países, algunos lugares en los que se establecen redes solidarias y hacen un llamado o un autonombrado y ellos se nombran de que todos somos tribus, todos somos parte de lo mismo. Y el precepto que ellos tienen es que no vamos a dejar nunca a nadie atrás, todos hacia adelante porque todos pertenecemos al mismo grupo. También en este caso los apoyos alimentarios que se estuvieron dando para mucha gente que realmente pensábamos que no iba a suceder, pero sí hubo gente que no tenía hasta ni manera de comprar alimentos para subsistir. Establecer las redes para cuidados de los menores y de los discapacitados. Nosotros pensábamos que los menores y los adolescentes parecía que no tenían tanto problema, que no se iban a enfermar demasiado, que no iban a tener mayor problema, pero sin embargo estamos viendo últimamente casuísticas, números de pacientes, niños que han fallecido y que se han estado haciendo las autopsias y apareció un síndrome inflamatorio multisistémico, SIMS, ¿sí? Y se le hicieron pruebas y resulta que estos niños habían tenido COVID asintomático, pero como un problema post-COVID, este síndrome inflamatorio multisistémico. Entonces necesitamos establecer redes para todo esto, redes para el cuidado de los niños sanos y sobre todo los discapacitados que tienen necesidades especiales. El apoyo psicológico es indispensable por la situación del estrés, por la situación de la tensión, por la situación del desgaste por empatía que ha tenido la gente y los profesionales de salud y las asesorías médicas que ojalá podamos continuar proporcionando en línea o presenciales, pero en este caso pues poder dejar organizada una red médica por profesionalistas de la red sanitaria pública como de la red privada para atender a estos pacientes. Eso es todo por el momento, esa es toda la información. Muchísimas gracias por su atención. Aquí estamos para cualquier duda o para cualquier comentario. Gracias.
Muchas gracias, Dr. Wakamatsu. Muchas gracias.
Thank you very much, Dr. Wakamatsu.
Our next presentation
Nuestra
will be Ms. Diana Gomez. Diana Gomez is the Director of Public Health for the Yuma County Public Health Services District and has worked in public health for over 20 years.
Alex, it looks like you're speaking. We can't hear you.
I'm not on mute, so I don't know.
Yeah, we can hear you, Alex. I can hear you.
We can hear you.
Oh, okay.
I can hear you.
Okay, thank you. So as I was saying, Ms. Diana Gomez is the Director of Public Health for the Yuma County Public Health Services District. Ms. Gomez has worked in public health for over 20 years and has served on various local, state, and national committees. She's a Flynn Brown Fellow, a Project Central alum, co-president of the Binational Health and Environmental Council, and was recently recognized by the Kresh Foundation as an emerging leader in public health. Ms. Gomez, thank you for joining us.
Good morning, everyone. I actually don't have a presentation, so I was just hoping to talk to you a little bit about what the public health perspective was from our side. So thank you so much for giving me the opportunity to be with you this morning and for highlighting some of the challenges that we experienced, as well as some of the really good things that came out of when you look at, people coming together. And I know that we always say that UMA is really unique in that, but we truly are. So when you look back at the trajectory, we had our first case back in March, and from that point to now, we've had over 37,000 positive cases. And unfortunately, we had over 800 deaths. And those are, people, you look at those numbers and they're not numbers, they're family members, they're loved ones, they're friends, they're people that are no longer here. And so again, every time we see those numbers and realize they're not numbers, but they're people, our heartfelt condolences. And again, knowing that, we're in a better place now than we were back then. Yeah, but now we have better treatments. We know more information. In the early days, we were kind of in a fog. Every day was something new, something different. And so when you talk about trust, when a pandemic like this happens, and we're talking about what we need to do to move forward, how to protect people, how to educate people, communication is paramount. And one of the challenges that we faced early on was the fact that the science was evolving. We were learning more every day, and that meant we had to go back and revise things. And so sometimes that created confusion in the public. We knew right away that this was similar to other SARS viruses. So we knew that there was non-pharmaceutical things we can do. Non-pharmaceutical interventions were the things that we discussed early on, like hand washing, increased cleaning, wearing of face coverings. So we used the face mask, and social distancing. But again, as the guidance evolved, we would go back, and it got to the point where, publicly when we did, briefings or interviews, we'd say, as of today, and we literally said the date, and we had to acknowledge that, that was going to change. And it was important for us to tell people, look, this is what we know at this point. As we learn more, we'll keep you informed. And I think letting people know that that was going to happen was important in building their trust and confidence, because otherwise they're like, okay, so everything's changing. What do I believe? So the first cases we had were travel related, and we know that Yuma County got hit hard, and there were several factors for that. Number one, our geography. We border Mexico to the south, and we border California, and there's a lot of cross-border movement. We're a very fluid border. We have a lot of travel. We have 2 military bases. So again, it was a matter of time. And what makes our community great, the diversity, the ability to go back and forth, also posed challenges when you're dealing with a virus that's highly communicable, that was airborne. And again, we know that viruses they don't know about borders. And so again, the challenge was, and the important thing was communicating with our partners. So again, very grateful to the Secretaría de Salud and their leadership, very grateful to Robert Guerrero, who's here from the Office of Border Health, for coordinating those meetings, to Regional Center for Border Health, to Imperial County, because we had those dialogues, and we recognized that Yuma County, our residents, go back and forth, and the border is a region. It is not just a stagnant place. There's movement. And so for us to protect our residents, the residents that we share, the community that we share, it was important that we work together and we have that dialogue and we share those best practices, what we were learning, especially early on when knowledge was very limited. So the other thing that was an issue here in Yuma County was, we're talking about social determinants of health. And we know, particularly in certain areas of our county, we have housing. We don't have a lot of, one of the issues with social distancing was when if you were found to be positive for the virus, we said socially isolate, go to another part of the house, go to, use the master bathroom if possible. Well, that's not a possibility when you live with grandma, grandpa, there's maybe 7 people in the house. So that was a challenge. There's that inequity where sometimes people live multi-generations, which also put people at risk, because you had really young people living with their elderly grandparents, because that's what, particularly in the Hispanic culture, that's what we do, right? We live with grandma and grandpa, and so we take care of them. So that was an issue. Also on the border, as was brought up earlier, we have a higher rate of chronic disease. So we knew early on that people that had chronic disease had a higher higher predisposition to developing complications related to COVID. So we have a really high rate of hypertension, we have a high rate of heart disease, and we have a very high rate of diabetes. So again, those are things that most of the stakeholders, the community partners here that work in healthcare are aware of, but this pandemic really brought those inequities to the forefront. And I could tell you that again, you know, the majority, we knew when we were looking at vaccination, we knew that over 75–80% of hospitalizations, of complications and deaths were among our residents that were age 55 and over. So again, things that we need to keep working on, and that, you know, this pandemic really brought to the forefront. So the challenges early on again were, you know, the misinformation out there. A lot of people thought that, you know, maybe this wasn't so serious, or they didn't know somebody, they had heard of somebody who knew somebody who got the virus. And eventually, unfortunately, that circle closed in, and then it became somebody in your family or somebody in your neighborhood or somebody at your workplace. And so as that happened, I think people became a little more willing to you know, wear the face mask. But again, as you know, that became a really sensitive and polarizing issue, even though it was a science-based, you know, non-pharmaceutical intervention that was easily acceptable to everybody. So again, those are things that we still, you know, continue to work with. Another challenge was in our border community, we have a lot of agricultural workers, and we have a lot of, you know, frontline workers like grocery store workers, who sometimes, you know, you have your shift and you just can't call in shift or call off and say, you know, I'm going to take my medical leave off, you know, today, or I'm going to use my PTO. For a lot of people, missing that day of work is missing that daily wage, which makes the difference, you know, that they've got mortgages to pay, they've got families to support. So that was a real challenge as well. You know, as we started seeing our numbers climb, and just to give you some perspective, our positivity rate, the rate at which, you know, we were reporting how many of the percentage of our population that was infected with COVID, at one point in December, the high was 33%. And we were averaging about maybe at some point 300, 400 cases a day in December. Fast forward to now, and with some of the therapeutics, our vaccination rates, some of the interventions that we've used, we are down now to a 2% positivity rate in Yuma County, and we're averaging about 5 positive cases per day. So that's a testament to all the work done in this community, done by all the community partners, done to everybody that's helped with vaccinations, with testing, that we've able to make those strides. You know, just to give you some perspective as far as vaccination efforts, we now have in Yuma County administered over 161,000 doses of vaccine, which roughly translates to about 39% of our residents being vaccinated, and 75,000, close to 76,000 of those residents are fully vaccinated, meaning if they partook of the Moderna or Pfizer, which is a 2-dose series, they are now fully protected. As many of you know, the Pfizer vaccine was recently approved for ages 12 to 15. So anybody that's over the age of 12 can now have the Pfizer vaccine. The Pfizer company is looking forward to seeking full authorization from the FDA sometime, hopefully in September, that would allow them, if everything goes well, to maybe as early as September or October maybe, have the ability to vaccinate ages 2 and up, which would make a great difference in being able to move towards a higher vaccination rate in our community. So again, challenges that we saw with the pandemic, one of the big things that we had to be aware of was that we knew that there was going to be a high level of infection. Our concern was not to overwhelm the healthcare system. And so we have one hospital here. So we needed to do several things. So working really closely with the Arizona Department of Health Services, and I can't really emphasize my gratitude to the state health department and for all the assistance they provided for our community. One of the things that made a huge difference was the establishment of the surge line. So this medical surge line allowed hospitals across the state, including ours, the ability to transfer high acuity COVID patients to other hospitals that had available beds in the state. This allowed local hospitals to be able to accept patients that were non-COVID and continue to provide those services, because we know that people in the community are still going to need to access the emergency room. People in the community are going to have, serious health issues, like they're going to have, heart attacks, strokes that they need to be treated for. So the ability to have a transfer line and use those services was critical in helping us ensure that our local healthcare system was not overwhelmed. Another really critical thing that the Arizona Department of Health Services, ADHS, played a critical role in is working with us to make sure that we had PPE. And so working really closely, we were able to distribute PPE, protective equipment, to nursing homes. We were able to distribute it to a lot of congregate settings. We distributed to schools, law enforcement, first responders, and of course our hospital. The other thing that ADHS assisted us with was being able to, you have these frontline providers, particularly our clinical care providers, the nurses, the doctors that were in our ER, in our hospital, that were treating COVID patients day in and day out. So the state worked with us to be able to procure staffing and be able to procure both behavioral health services to assist with the fatigue and the the mental health and behavioral health toll, as well as strike teams that would come in for about 3 weeks and rotate out to be able to provide very, very needed and very, very critical support to our healthcare providers, frontline nurses and physicians that were providing critical care. So it allowed them a bit of a respite to be able to at least have some reinforcements come in. And so again, very fortunate. They also the state also helped us procure additional ventilators. So it was truly a very consistent, coordinated effort to make sure that we continue to support our clinical care infrastructure. Now, aside from our hospital, we had our clinical partners that played a very pivotal and vital role in testing. They helped us, by testing members of the community at different sites. So we had, for example, Sunset, and we had Regional Center for Border Health that have clinics in San Luis, Somerton, in different areas in the community. So that allowed, some breathing room for our healthcare providers as well, because they were providing testing and they were also seeing patients. So really, it goes back to validate the importance of investing in healthcare and investing in those frameworks and making sure that the communication's in place and making sure that we have strong partnerships so that when things like this happen, because we prepare for this pandemic, but we never thought that we'd be dealing with it for months and months and months. And I don't think anybody ever anticipated the scope and the length that it would last. So, other things that we needed to work on was, again, ensuring that our healthcare providers, law enforcement, first responders, everybody that needed it, our nursing homes had protective equipment. We also needed to make sure that they had testing. And as rapid tests became readily available, we were able to share those with the different congregate settings, the different clinical providers, so that they could use it and we could test, more readily in the community. We had our clinical providers that were able to do testing blitzes that allowed people in very flexible hours, on Saturdays, on weekends, on evenings, to go get tested free of charge. So again, when you have the ability to go get tested, it gives us perspective as far as we know where the numbers are, we know where we need to be. So those were some of the challenges. We in Yuma County also hosted the Centers for Disease Control on 3 separate occasions. They came down here to help us work with our migrant population, our migrant workers, and we were able to again partner with some of our community agencies, like for example, in this case, Campesinos Sin Fronteras, who do amazing work with their promotoras. And so again, working to do outreach, to schedule vaccination clinics for our farm workers. And so we were one of the first entities to reach out to the farm working community. And so I know that, Campesinos played a really good, big role in that. I know that Sunset did. I know that Regional Center took their mobile unit and did a lot of those vaccination clinics. And again, when you talk about equity, It's about making sure that people have access to services wherever they reside, so that things like inability to pay for a service or lack of transportation is not a barrier. And so thank you to those partners who, in addition to us, went out to the community, and we took the testing to them, we took the vaccines to them. And I think that also made an impact as far as driving down those numbers. We also worked with our agricultural companies to evaluate migration patterns with farm workers and know where they were going, where they typically came from, their harvesting routes that they followed, and some of those things, because we knew early on when vaccine supply was limited that we at that point only had the 2-dose vaccines, either the Moderna or Pfizer. So it was important for us to be able to coordinate the second dose of that vaccine. If they got their first vaccine in Yuma County, we wanted to make sure that if they were going to California, we could coordinate with that healthcare clinic or site to make sure that they got their second dose there. And we were able to do that successfully. And then we had some agricultural leaders that actually worked with us to provide wraparound services, where if one of their workers came up positive, provided alternative housing and wraparound services like laundry services, food services while they were there. And then our team went in and checked on them while they were in their isolation and quarantine to make sure that they were okay. So those were some of the creative out of the box type of things that this pandemic really, really brought to light. And so, initially the challenges were staffing, PPE, and just education. And again, huge kudos. I know it's just, I'm coming from a place of gratitude just because it was so challenging in the beginning, but to our state universities, because when we did not have testing supplies, U of A, they were developing the swabs and the testing kits, and they were like, what do you need? We'll make sure it goes out to the rural communities. When we started doing our testing events, our COVID testing events, and when we started doing our vaccination clinics, our Arizona Western College and NAU nursing students were front and center. They were at every event. They hosted, I think the very first vaccine event we did something like 600 people in one time. And day in and day out, those students and their clinical instructors were here. They were providing that vital support when the rest of the healthcare team was exhausted. It was those students that came to the rescue. So huge, huge, huge debt of gratitude to our community college and our state universities and our nursing students and public health workforce, because they made a difference. They filled in the gap. And when our role was to protect the community, their role really was to be our support system and our backup. And they really made a critical and very important difference. So moving forward, I think now that we've seen some of these things that unfolded, some of these challenges, we really need to focus on being resilient and coming back stronger. We have to look at, and it's okay to say, look, we didn't know enough. These are the decisions we made. We know this now, and plan for the next phase. And it's important to be vigilant, because we don't know what this pandemic is going to look like. We don't know if it's going to just taper down and then surge again. We don't know. That's the reality. And so we need to be prepared. And so, as far as preparedness goes, it's important to be vigilant and plan and coordinate and anticipate. And I remember we were co-hosting with Arizona Western College, a pandemic tabletop exercise. And this was at Arizona Western College. And Dr. Elliott Nelson had put that together at ABRC, and we had invited schools. She had invited schools from Sonora, Mexicali, and schools here from Yuma County. And we were talking about what would happen if there was a pandemic or an infectious disease outbreak at a school. And so we were working through that exercise, and that was a Friday afternoon. And the very next day, on Saturday morning, was when we were notified that we had our first COVID case in Arizona, and it actually was in a school. So it just goes to, so they just transitioned to their plan, because they had been doing those types of exercises. And it's a testament to Dr. Elliott Nelson and the leadership at AWC that they were planning ahead. So again, moving forward, we need to focus on continuing to provide vaccines, addressing vaccine hesitancy. It's important to acknowledge that a lot of people still have concerns There's a lot of misinformation, but it's important to acknowledge those concerns. And more importantly, not just acknowledge those concerns, but have the opportunity for those people who have those concerns to ask questions, to have a dialogue. Because a lot of times when they're able to walk through their concerns, they come to a different understanding and they're willing to reconsider, or maybe they didn't know the facts. So again, it's important to give those opportunities for people. It's important to continue to take our vaccine efforts out to the communities, to the community centers, out to work sites, out partnering with schools, so that it's accessible, so that things like lack of transportation or lack of regular access to healthcare or language barriers are not an issue for your ability to take a vaccine. It's important to remember that as we go back to school and our schools reopen, to support our schools so that those kids can go back and do it safely. It's important to recognize the behavioral health impact that this pandemic has had on all of us. We are social people. We've been doing all this stuff to Zoom. And so as we move to resume our daily, whatever our new normal is, as we slowly transition back to that, it's important to acknowledge the behavioral health toll that took, and invest and recognize the importance of behavioral health. It's also important to acknowledge the disparities that we always knew were there, but this pandemic really highlighted. And we can't unsee what we saw. We can't unsee that we have a lot of work ahead of us, but it's important to acknowledge that we are coming out the other side of this with a heightened sense of awareness and hopefully a heightened sense of purpose, and the understanding that we weathered, the really bad part of this storm together, and that together we can continue to face and make a difference and make an impact in our community as we move forward. So that was it for me, and I'll answer any questions after if anybody has any. But thank you so much for your time.
Thank you, Ms. Gomez. And our next speaker, I think we're just about 10 minutes off, but our next speaker is Mr. Robert Guerrero. Our next panelist is Mr. Robert Guerrero. Robert Guerrero serves as the Chief of the Office of Border Health for the Arizona Department of Health Services. Mr. Guerrero functions as the primary liaison and point of contact between the Arizona Department of Public Health and the Arizona Department of Public Health and the public health authorities for the state of Sonora. Welcome, Mr. Guerrero.
Thank you very much. And it's great that it went in this order with Dr. Ramirez Wakamatsu and then followed by Diana Gomez. I love the order that this went into. So next slide, please. So just a little bit about where my office is located. I can't control these, right? You guys are recording? There you go. So my office is actually in the Office of the Director in the Division of Policy and Intergovernmental Affairs. And I serve as a primary liaison between ADHS and Mexico, primarily Sonora, but it's not limited to the state of Sonora. And I serve as the director's delegate to both the U.S.-Mexico Border Health Commission and the Arizona-Mexico Commission, mainly in the policy area. And so my main area is binational communication, coordination, and collaboration. So next slide, please. So for those that live in the border area, now's a good time to check your emails because you know all this stuff. But those of you that are unfamiliar with the border area. So historically, this is the flow that goes back and forth between the United States and Mexico. And I like to borrow a term from our Native American colleagues, since time immemorial. This is the flow back and forth. And I like to emphasize not just northbound, but southbound as well. This is a historical flow back and forth across the United States and Mexico. Next slide, please. This is the border region, and it's defined by the La Paz Agreement from that was established. And so it's 100 kilometers north of the United States border and 100 kilometers south of the border. And for those of you that aren't familiar with the metric system, it's 62 miles north and 62 miles south of the border. Next slide. And this is specifically the Arizona-Sonora border. From the east, Douglas, Agua Prieta, to the west, San Luis, Arizona, and San Luis Rio Colorado. And then I'm just going to take you, and this is mainly, again, for those people that aren't familiar with the Arizona-Sonora border. The next slide, please. Starting from the east, Douglas, Arizona. Actually, the population of Douglas dropped shortly after the hospital in Douglas closed. It was one of the rural hospital fatalities back in, I believe, 2017. Anyways, I won't go into that politics right now. But if you'll notice, at that time, the population was about 16,000. I think it's right around 15,000 now. Next slide. And then you have Agua Prieta, right around 80,000. That population has actually increased. And INEGI, which is does the population surveys, actually they just redid those, just like we did our census here in the United States. So those, I think Douglas went down and Agua Prieta went up. But I want you to kind of notice the dynamics, that on the US side you'll have a smaller town, and on the Mexican side you'll have a larger town. But what's key on these is that there's in the Arizona-Sonora border, unlike the Texas border that has a river, we're just divided by a small line. So next border, or next slide, please. So this is Naco, Arizona. Next slide. Naco, Sonora. And they're, again, just, and actually my family actually migrated through this area because my family came from the Rio Sonora, came through Cananea, Naco, into Bisbee. Next slide. Nogales, Arizona. Next slide. Nogales, Sonora. Next slide. The Tohono O'odham Nation, and what's interesting and what's important to bring up here, and actually I bypassed Sasabe, Arizona, and Sasabe, Sonora, and so, but anyways, what's important to note here is that the Tohono O'odham Nation extends onto both sides, because this nation existed before the United States and Mexico, and so they have members that exist on both sides. And they cross over and across the United States Mexico boundary. Next slide. I put this on here because Lukeville, Arizona, which basically on the U.S. side is a port of entry. And then next slide, you have Sonoita, Sonora, which is an important intersection for Mexico, because this is, you'll see highway number 2, which is an important route for Mexico, because this actually connects Baja California with the rest of Mexico. And also, this is an important port of entry for the United States, because Lukeville and Sonoita connect Puerto Peñasco, and so this is a really, really important tourist destination for the United States, and so a lot of traffic moves through here. But just noticing the population of Sonoita, and then next slide, you'll see San Luis, and really, to be fair, I should be saying San Luis, Somerton, and Yuma, and then next slide, we have San Luis Rio Colorado, which the population is much higher now as well. So I just wanted to give you that overview, understanding that how our border region is related. And next slide, please. And so one of the messages I want to really emphasize here is that we are the Arizona Sonora mega region. We are one region. And if we don't treat it as one region, we fail. Next slide, please. So going to COVID and why we're here today. On March 11th, 2020, Governor Ducey signed the emergency executive order declaring a public health emergency. So next slide. And then on March 20th, is when the borders, if you'll back up one, please. There you go. Actually, there you go. So the borders were closed, and this actually caused some confusion because, so this is from Customs and Border Protection when the United States border with Mexico and with Canada was closed, and these were the ground borders. These were the and the confusion was on the southern border is that we understood that the border southbound was closed as well. Canada did close its border to the United States, and so it was closed to non-essential travel. But key here, if you look at the first part, was U.S. citizens and local permanent residents were able to return to the United States. Individuals traveling for medical purposes were able to cross the border. Individuals traveling to attend educational institutions, individuals traveling to conduct essential work in the United States were able to cross over. Individuals traveling for emergency response and public health purposes. So just keep this in mind because this will play into later on in my discussion here. But what was confusing was that this was for northbound traffic. For southbound traffic, Mexico at the federal level was not enforcing the same. So next slide, please. So, and you'll have to forgive my gallows humor. So this was when the pandemic was still in diapers. On March 19th, 2020, Arizona had a total of, what did we have? 300 and what? I can't see the number there. Anyways, we had very minimal number of cases. Maricopa had 22. Yuma County had 0. Sonora, the state of Sonora had 2 cases. In fact, and one of the key things that I did right at the very beginning of this pandemic is we had a lot of information, misinformation that was going on. And so I contacted Dr. Gerardo Alvarez. Dr. Alvarez is the Director General de Promoción a la Salud y Prevención de Enfermedades. So he's the Director General of Health Promotion and Disease Prevention for the state of Sonora. I call him the Dr. Anthony Fauci of Sonora. And as the Dr. Alvarez, it's very important that we exchange credible information on a real-time basis. So we begin exchanging information on a daily basis, 7 days a week. And to date, we have exchanged over 730 reports, north and southbound. And so the colleagues on the line that receive the reports know what I'm talking about. So this was in the infancy of those reports. And so this was at the very beginning. So Sonora had just reported their 2nd case. Next slide, please. On April 22nd, and I put this slide here because this is the day that I got a call from Diana Gomez. And Diana contacted me and said, actually, we had our first call. And it was a call with Diana Gomez and with Dr. Eric Lutz from the Arizona National Guard. And we had an issue going on. We had a dynamic that was developing. If you'll notice, Yuma County had 28 cases with 1 death. And San Luis Rio Colorado had 79 cases with 4 deaths. And the dynamic that Diana was talking about was, Robert, we have a lineup of cars southbound going into San Luis Rio Colorado. I can't figure out what can we do about this. And it was a real issue because this was a lineup of, and it was a lineup of people also that were going southbound into San Luis Rio Colorado. And so what we ended up doing was we ended up convening a series of binational Zoom calls that soon escalated into border-wide Arizona-Sonora calls. I started out with Yuma County and Jurisdicción número 6 with Dr. Ramirez Wakamatsu, and then pretty soon we had Cochise County, and then we had and Santa Cruz County as well, and then the other, we had Nogales and San Luis Rio Colorado. And so, next slide, please. Exactly 1 month later, you look at Yuma County has 492 cases with 7 deaths. San Luis Rio Colorado has 269 cases, 32 deaths. And so things are really jumping up here. And I remember at that beginning, the comments were, tell the Americans not to come down here because they're going to get sick. Next slide. 1 month later, Yuma County has 4,591 cases with 56 deaths, and San Luis Rio Colorado has a total of 731 cases. And now was tell the Americans to stop coming down here because they're going to get us there. I'm not going to show you more numbers because, well, I could cut to the chase and say that as Diana Gomez said, today, Yuma County has 37,179 with 837 deaths, and San Luis Rio Colorado has 3,176 cases with 500 deaths. Next slide. But what I want to do is I want to talk about these binational Zoom meetings that we had. So we conducted over 25 binational meetings. At the beginning, they were weekly meetings, and what we did is we used the platform of the Arizona-Mexico Commission along with the Arizona National Guard with Dr. Eric Lutz. And what we were doing is we wanted to provide this platform for the epidemiologists and the health departments to what are the issues that are going on. And I put on here, and this was actually a quote from Dr. Ramirez Wakamatsu, the tortillas y carne asada. And this was a frustration because people were coming down from Yuma, from Somerton, from San Luis, Colorado. They were going to San Luis Rio Colorado to buy tortillas and then have their carne asadas on weekends. And what, you know, is what could we do about this, you know, and how could we change this, and why are they coming down to buy tortillas and carne asada? So I'll address that a little bit more in just a minute, but I mean, and it was seriousness. It was this, you know, what can we do? Next slide, please. The partners that were on that call. From Arizona, we had obviously ADHS. We had folks from our BIDS program. We had U of A College of Public Health, Dr. Cecilia Rosales. We had Dr. Eric Lutz from the Arizona National Guard, the county health departments, Diana Gomez. We had Santa Cruz County Health Department. We had Cochise County Health Department, Benito Lopez, of course. On there, we had NGOs at Chiricahua Community Health Center, Campesinos Sin Fronteras, from Sonora, the Secretaría de Salud, the health jurisdictions, the border epidemiologists, and we would start out with epidemiological information, and we would discuss what are the issues that, you know, we all knew the numbers because we put the reports out. But then what are the issues that the numbers aren't telling us? And that's where you start to get the stories. That's where you start to get all these other issues that sometimes the numbers don't tell you. And that's where you start understanding that, well, it's because, you know, you have multi-generational families that live in houses, and that social fabric of families, and yeah, they go down to Mexico on weekends to be with family because that's what they've always done, and that's how families operate. And so we had to learn how to develop messaging that would resonate with these families, because standard maybe wouldn't. So next slide, please. So one of the things that we did in partnership with the U of A MESCOP, we together a repository, a binational repository of messaging and infographics that we were able to develop. Some of the messaging came from Sonora because they had excellent information that they were able to share, and some of it came from Dr. Eric Lutz, and some of it came from, you know, we compiled it together and tried to work on messaging that would work, and then some of those social determinants were actually I would call it medical social determinants. I mean, based on where you lived and what type of medical health care you received. You know, I jotted down the surge line. You know, we had this surge line on the US side. The surge line didn't exist on the Mexican side. And so that in itself caused some issues. Next slide. You know, one of the things that we did at the request of Sonora, we, in partnership with Tucson Medical Center and the MESCOP and the Melanie Zuckerman College of Public Health, we did a series of medical seminars on the medical management of critical COVID patients. Had over 900 physicians on the Mexican side that attended these, and it was how to, you know, many of the hospitals, many of the small hospitals on the Mexican side couldn't ship patients out. So they had to care for those patients where they were. And that meant instead of you know, sending patients out, they got a ventilator and they got a heart monitor, and they had to take care of patients right there. Maybe the last time they took care of a critical patient was when they were in medical school. And so so a lot of the information that we were sending was focused on helping them care for those patients. Next slide, please. So really, it was looking at those diverse border populations, and a lot of what we talked about was, you know, those understanding that you had these populations of people that, for instance, you live on the U.S. side, but you work in Mexico, or you live in Mexico and you work on the U.S. side. You have U.S. citizens that live in Mexico. You have permanent U.S. residents that live on the U.S. side. And then you had the H-2A farm workers that live in Mexico. And I think that this really made for a really interesting set of circumstances, because especially when it came to the epidemiology part. For instance, somebody that lived in Mexico, worked here, they got tested here, but then they went back, and then the county health department would contact us and say, well, we have a positive, but they live in Mexico. What do we do with the results? Now, Arizona has a system called MedSys. It's a medical electronic disease intelligence system, and Sonora is on that system, and we're able to electronically share that type of information with Sonora. So we have the border epidemiologist on the Mexican side on that system, and we're able to electronically share those outcomes. So we were able to do that contact investigations. Michelle Cruzberg Martinez, who's our bids officer here in Arizona, was able to develop a line list every week of positives and send those across. But it was very common to have that, where you would have those patients that were tested here and went across, We had Mexican citizens that worked, for instance, a case we had in Nogales, where we had a Mexican citizen that worked at a bank. So it was a person that was in a job that needed to be done, but she tested positive. And so how we got that information back to her, and of course keeping HIPAA and all this type of information. Next slide, please. And so I got this this call, and I'll be respectful of the county that sent me this, saying they're sending us their patients. And so when I tried to do research on, well, who is the patient, and they couldn't tell me who the patient was. They couldn't give me the information because of HIPAA. So I found out the port of entry, and actually I called the town in Mexico, and I spoke to the Cruz Roja, because that's actually who would have sent the person. And when I talked to Cruz Roja, they explained to me, and I said, I don't mean to be rude, but and don't take this wrong, but was it a U.S. citizen? And they said, well, yes, of course. And as it turned out, all the patients that they were sending were U.S. citizens. Now, these were patients, and without going into the political side of the 14th Amendment, all these patients were born in the U.S. but had lived their entire life in Mexico. And now that they were critically ill, they were choosing to come to the United States, where they were U.S. citizens. And when I talked to Customs and Border Protection, they verified that. They said, yes, Mr. Guerrero, these are U.S. citizens, and they have every right to come across. You know, these are some of these dynamics that you run across that are, you know, a challenge. Next slide, please. So, and another challenge that we run into is the number of U.S. citizens going southbound into Mexico. My brother-in-law owns a house in Puerto Peñasco. Actually, he owns a house in San Carlos, Guaymas. And I remember telling him, Lance, you can't go into Mexico because the border's closed. Last year, he went to San Carlos 6 times and never had a problem. And I kept telling him, Lance, don't do this. We're in the middle of a pandemic. There are thousands of Lances, thousands of U.S. citizens that went southbound. And it made me upset, because I felt like my brother-in-law should have stayed in place. He was putting himself at risk, and he was putting Mexican citizens at risk. And so this mentality that's get up and go, and the fact that for whatever reason Mexico was not holding them at the border. So you know, this is, you know, I don't know if it's a social determinant or what, but we were going south. A lot of time in preparedness exercises, we always worried about this surge of patients, a surge of people coming from the south. We worried about that when H1N1 hit. We worried about it. Almost any pandemic exercise that you do, I guarantee you, tabletop exercises, you're worried about a surge coming into the U.S. What we see in reality is that doesn't exist. The truth is, we have more people going from the north traveling south. And so I think we have an opportunity to learn from this pandemic. It's the largest pandemic that has ever hit the earth. And so we need to know that the border region is unique, and communities straddle the border. And we have to work together on this, and we have to understand that there is this constant flow of populations that are going back and forth every single day. The border was closed, quote unquote, But the truth is that every single day, people were going back and forth. So what we did is we put up an economic filter. And by that, I mean is that the border was closed, the ground border was closed. That meant that people living in Nogales, San Luis Colorado, Agua Prieta couldn't come across to Walmart. But people living in Hermosillo could still catch a flight to Phoenix and go shopping anywhere they wanted. Those people that had money could fly anywhere they wanted, land in the United States and do what they wanted. Those people that tried to cross the land border could not. So I think we just need to learn by this. And I would challenge those people doing preparedness exercises to really look at those exercises and maybe develop something that would be that would look at the realities that we are seeing today, and really look at, you know, how do you develop a tabletop that would address communities the way they really are, and families that, you know, people that you know, why do people go across to buy the tortillas? Well, you know, part of it's an economic issue. Part of it is, you know what, it's cheaper, and it's the way I've always done it. And it's, you know, I go and I buy my groceries, and this is the way I've always done it, and it's the way our family is. And, so I'm going to stop there, and next slide. I think that was it. Thank you.
Thank you, Robert. Our next speaker is Dr. Joe K. Gerald. Dr. Gerald is an associate professor of public health policy and management at the University of Arizona, Zuckerman College of Public Health. During the COVID-19 crisis, Dr. Gerald has been recognized as one of Arizona's leading public health voices. Welcome, Dr. Gerald.
Great, thank you. It's wonderful to be here, and it's really been interesting to hear some of the in the weeds stories about what's been happening. I've been somewhat distanced from that here in Tucson, and the direction of my talk is going to be from a broad 30,000 feet. So hopefully I can add some contextual layers over some of the really interesting material we've heard already. All right, and so I'm Dr. Joe Gerald. I'm an associate professor of public health policy management at the University of Arizona, and I've been working alongside my colleagues to help the state understand where we are in the pandemic and where we might be 4 to 6 later, with modeling and forecasting in collaboration with Northern Arizona University and Arizona State. I'm not going to be showing some of that data today. Instead, I'm focusing on the big picture of how we draw connections between the social determinants of health and COVID-19 outcomes using some data that's been developed more at a regional or national level. Next slide, please. And so just a quick refresher, the social determinants of health, they're the social, economic, environmental, and political conditions in which people live, work, and play. Essentially, the social determinants are all around us. And in some regards, they basically disappear into the background of our everyday lives. And so it makes it very difficult to both recognize and target them as potential interventions to mitigate the worst of COVID-19. But the way the social determinants impact health is through our ability to make healthy choices, to keep ourselves and our families and our communities safe, having accurate, reliable information, and then being able to act upon that information. The social determinants of health also shapes our exposures to harmful and protective behaviors. And so you might imagine being in an occupation that's deemed an essential worker, you are required to go into work, and because of that, you're exposed on your way to and from work. You're exposed once you get to work, and perhaps you're also exposed with the people that you interact with in the community. And so the social determinants help shape those exposures, and to the extent to which you face harmful or protective behaviors. And lastly, social determinants exert power over how much you can fully participate in society and help establish the rules that guide the interactions between all of us. For instance, your ability to influence whether your county or state perhaps does a lockdown or requires masks, something of that nature that empowers you to take control over your life and exert some effect there. And these social determinants are influenced by the distribution of money, power, and resources locally, nationally, and globally, where our focus here today is really going to be at the national level. And so some of the common things that are studied, because they're easy to study: income, education, race, and ethnicity, because we often collect that data. The social determinants are much, much more broadly defined, but will not be really the topic of what I'll be talking about today. Next slide, please. Yeah. And so one of the big things that we've studied historically has been in the relationship between income and health. And what we're looking at here on this data, so I want to focus you on the left-hand side of this graphic where we're looking at the all columns. And what we're seeing on the vertical axis is the number of Americans who self-report poor or fair health, and that's not good. Ideally, you would report excellent or very good health. And so if you are high, if your column is high, that's bad. If your column is low, that's good. And then each column within a group represents your income status, with the lowest income being on the left, less than 100% of the federal poverty level, and the highest income categories being on the right in black, greater than 400% of the federal poverty level. And so what we see is this stair-step relationship between self-reported health and income, such that each step higher on the income ladder, self-reported health is better. And that's true for each and every increment in income. And so when we think about particularly relationship between income and social and health outcomes, this is not poor against everyone else. This is the very rich against the rich against the professional class against the middle class against working class, right? These gradients exist throughout our income distribution, and it's relevant to all of us no matter where we sit on that income distribution. And then the second thing is we're all in this together, particularly by race and ethnicity. These stair steps are evident within Black communities, within Hispanic communities, within white communities. This relationship is consistent, it's repeated, it's observable almost everywhere that we can look at these things. And so income matters. Next slide, please. All right, and so some have argued, well, what's the connection between self-reported health? Maybe people get it wrong, and maybe we shouldn't trust this data. And so these data try to connect income from tax records with health outcomes being mortality from national statistics, right? So it doesn't get any more objective or concrete in this. And what we're seeing on the vertical axis is the expected age of death for 40-year-olds in years, right? And so you've made it to 40. What's your expected age at death? Higher being better, lower being worse. And then on the horizontal axis is income from very low levels to very high levels on the right. The dashed vertical red line represents median household income, right, which is about $61,000 in the United States. Then we have a red line that's more horizontal but curved, and then a blue line that's horizontal and curved. And this represents the relationship amongst men and women. And so whether we're looking at men or women, there is an important relationship such that lower income individuals can be expected to die sooner than upper income individuals. And this gradient exists through a large swath of the income spectrum. Again, this is not just an issue of poor individuals and the health burdens they face, but rather it's something that's relevant to all of us, even if we are in the professional class, because this relationship exists up through $300,000 a year in annual income. Of course, the other thing is, as what we all know, is women are actually the stronger sex as they live longer at every increment of income than men. And so the gap between the richest and the poorest man with regard to life expectancy is 15 years. That's a huge number. The gap for women is smaller, but still large at 10 years, right? And so there's good evidence that income matters. Next slide, please. Okay. And much of this exerts its effect through the policy environment that we live in locally. And so what this is going to show us is geography matters, but it matters more for the poor than it does the rich. And so what we're looking at in the horizontal axis, again, is expected age of death for someone who's already reached 40. When might they expect to die? The horizontal axis now is still income, but it's a different measure of income. It's breaking income into 20 different groups. Now we have 4 color lines, a blue line, red line, green line, and gold line. They each represent the relationship between income and life expectancy in a given city. And what we can see is the city with the steepest gradient between income and life expectancy is Detroit, Michigan, in gold, such that someone in the poorest income quintiles can expect to die many, many years earlier than individuals who are in the highest income quintiles. This relationship exists in all 4 cities, but some cities that relationship is stronger than others. If you could click the mouse button once, please. Yeah, and so again, there's large variation in outcomes by place. For those who are poor, click the mouse button again, please. But if you're rich, you have the ability, the resources, the wherewithal to protect yourself from the local policy and social environments within your communities. And so if you're rich, it really doesn't matter where in the United States you live. You can expect to live to be a similar age. However, the policies in place for the poor matter a whole lot. And so might imagine one that's obvious in healthcare is whether a state decided to be a Medicaid expansion state or not. Right? If you're an expansion state, then low-income individuals and their families have access to health insurance. If you're not in an expansion state, they don't, right? And so policies locally matter and influence health outcomes. Next slide, please. Okay. And so connecting this to COVID-19, what we're looking at is the Social Vulnerability Index, which is a multimodal index that captures household characteristics, income, education levels, community level factors, and tries to put it together in a composite that can rank counties from those who are most vulnerable, most disadvantaged, to those counties that are least vulnerable and least disadvantaged. And so on the left is a map of social disadvantage by county in the United States, with darker areas having greater social disadvantage or vulnerability and lighter areas having less vulnerability. The right side panel tries to connect this to COVID-19 cases and COVID-19 mortality. So the left A panel is COVID-19 cases, and we see time in weeks, MMWR weeks, moving from left to right as the pandemic progresses. And then the vertical axis represents cases per 100,000 residents. And then we have 3 lines, a gold, a silver, and a dark gray. And the dark gray is those counties that have the greatest disadvantage. And so what we can see is their cumulative rate of COVID-19 cases is much, much higher than those counties within a medium disadvantage range or the lowest disadvantage range. And those disparities grow even wider when we look at COVID-19 mortality in the B panel. It's the same structure, and what we see is there's a much bigger gap between that dark gray, dark blue line and the silver line and the gold line, right? Indicating in those counties who face the greatest social vulnerability or a disadvantage had the highest burden of COVID-19 cases and even higher burden of COVID-19 mortality. Place matters. Next slide, please. Okay. But income is not the entire story. And in fact, education may be a stronger explanatory than income itself. And so we're looking at a very similar graphic here with percent of individuals reporting fair or poor health, which is bad on the vertical axis, and then all Americans, and then Americans by various race and ethnicity categories. We see the same stair steps appear such that individuals with the lowest educational attainment, in this case, the white bars, not a high school graduate, are the ones who report the worst self-reported health, versus those with a college or technical school degree in black report the lowest levels of poor health, right? And this stair step matters across various race and ethnicity groups, indicating again, that these income issues, these education issues matter for all of us. It's not something that is focused on one community or another, but if we can address educational attainment more broadly, we can lift all boats together. Next slide, please. Right. And so education works through multiple pathways. And so educational attainment can work through knowledge, literacy, and behaviors, again, affecting choice and autonomy, these ability to make good health decisions and avoid bad health decisions. But it also influences the type of work we have and what type of exposures to harmful and protective behaviors that we might experience there through working conditions or during the pandemic, whether we have to go into work, we can work remotely, what amounts of PPE and how good are those PPE amounts in our workplaces, what are the other mitigation effects there. And then of course, the type of work we have influences our income, right? And then lastly, educational attainment leads to a sense of control, the ability to control our lives and our destiny. It improves our social standing and our ability to change the environments around us. So there are a lot of ways that education can impact health outcomes. So let's connect it to COVID. Next slide, please. All right, and so thinking about education levels and COVID-19 outcomes. On the left panel is a slide looking at weekly excess overall deaths per million residents. And then the horizontal axis is again time marching across left to right. In this case, we're looking at race and ethnicity so that we can see the patterns that we've seen in other chronic illnesses emerge here for COVID-19 as well, with minority communities facing higher burdens, particularly of mortality. So Black Americans facing the greatest burden of COVID-19 mortality, followed by Latino, white, and then lastly, Asians. But something very interesting happens when you split that out by education level. So what we can see is that an even bigger predictor of excess COVID-19 burden is identified by educational levels, such that individuals without a high school degree and those with just a high school degree or GED faced the greatest burden. In fact, 2/3 of the excess mortality was concentrated in these two groups, even though they represent a smaller proportion of the overall population. And those with some college or a college degree or higher faced much, much lower burdens, right? Drawing the direct connection between the social determinants that we know matter everywhere else, they matter in COVID-19 as well. Next slide, please. Right. This is looking at that connection between education and occupation and then COVID-19 mortalities. This is looking at mortality ratios by occupational class before the pandemic, mortality ratios by occupation during the pandemic, and then rank ordering those to see which occupational categories had the greatest pre-post difference in mortality. And so what we can see here is where the burden of COVID-19 mortality hit by occupation class was essential workers, cooks, packaging, filling machine operators and workers, agricultural workers, bakers, construction laborers, individuals who would be classified in the essential workers category. These are individuals who had to go to work to keep our economy running, keep foods flowing to people like me who were sheltered at home and able to mitigate my exposure to others. These individuals had to go into work every day, transport to, get home, be in that work environment. And so they are much, much higher risk than I was, being in a high education, high income occupation where Zoom was my exposure to others, right? And so we could take this information and then ask ourselves questions. So how should we be mitigating exposures in these areas? Are there things that we need to be doing differently in the workplaces? Do we need to provide different modes of transportation? How can we make the lives of these workers healthier and safer, given the fact that we need them to fulfill and keep our larger society working? So it's an opportunity to intervene. Next slide, please. Yeah, and so thinking about race and health, people often want to draw, I guess, comparisons between minority health and white Americans' health, and then say, you know, America would be doing a lot better if only we could address issues within our minority communities. And that's just a falsehood. It's absolutely the wrong way to think about it. And so what this interesting data shows here, thinking about infant mortality, for example, and the United States ranking compared to other countries throughout the world. And so if we combine all Americans together and then examine our infant mortality, there are about 6.8 deaths per 1,000 live births. And that ranks us 25th amongst economically developed countries. That's not very good, right? Normally we think America is supposed to be number one, but we're not. In fact, we're way towards the bottom of economically developed countries. What happens if you think about whites only and their infant mortality rate? Well, yes, infant mortality is lower amongst whites than minorities. And so by only considering whites, then we see a lower value, 5.7 infant deaths per 1,000 live births. But it doesn't improve our ranking. It's still terrible at 22nd out of the economically developed countries. We can play this game with maternal mortality, life expectancy from age 65. We're all in this boat together. And again, is one of my important communication pieces to my students and others that I talk to is that this is not something that should pit one group of Americans against another. We are all in this together. We're riding in the same ship, and things that make one group of us healthier will make all of us healthier. And we need to focus on the fact that as Americans, we're all doing poorly compared to others, and we need to address these social determinants sooner rather than later. Next slide, please. All right. And so thinking through the lens of race, again, let's focus on white individuals. So click the left mouse button, please. Yeah, great. And so what we're looking at here is COVID-19 test positivity, which looks at the relationship between the burden of disease within a community and the availability of testing within that community. And that's on the horizontal axis, with 25% being very bad, 0% being very good. And then we have colored dots here. And so the blues and the greens represent low household exposure risk, thinking about the circumstances in which you live and how likely COVID-19 might be to transmit within a household, with yellow, orange, and red values being high risk groups. And so when we think about white Americans here, what we see is that they're almost not, they're very uniformly blue, representing low household risk. And then they also live within communities in which the availability of testing is high relative to the burden of disease. It doesn't mean all white communities exist here, but many white communities compared to other communities exist in these low exposure, low positivity settings. Left mouse button, please. When we look at Latino communities, conversely, they're high exposure, high positivity, live in high exposure, high positivity circumstances. We recognize that because the distribution of dots goes very far to the right. Some communities existed where test positivity was 25%. That's huge. Those are very high and undesirable numbers, meaning there's a much higher burden of disease and availability to be tested and understand whether you have the disease. And then the dots are mostly yellow, orange, and red, indicating that there's a very high risk of transmission in those communities. And so, but it's not race per se, right? My argument is that it's income, it's education, it's occupation, it's the physical characteristics of the house and the household, multi-generational living, things of that nature. And that's what we need to focus on more so than the race. And what we're actually seeing here in the white communities are their relative advantage in terms of all of these social determinants. Next slide, please. Right. And so thinking about race and testing, so COVID-19 testing, what we see here on the left panel is testing and whether or not testing was deployed to the hardest hit communities. And what you see is this 45-degree light gray line that represents a line of equality. If the multicolor line overlaid this line of equality, then testing would be proportionately delivered such that communities with low burden had low amounts of testing, communities with high burden had high amounts of testing. And what we can see is testing was misdistributed during the COVID-19 outbreak, such that those communities that had low test burden, so low disease burden, did a lot of testing. In those communities where burden was disease burden was high, testing was not available. And so we had our public health resources poorly deployed through this pandemic, and being able to ensure testing was available so that individuals could react to that testing, isolate, quarantine, keep themselves and their families protected if they themselves develop illness. On the right-hand B panel, what we're looking at is the ratio of testing in whites versus the ratio of testing, in this case, just blacks as a comparison. The line of equality, again, is at 45-degree angle, indicating that if testing were done equally in white communities as they were black communities, then most of the dots would line up there. In fact, most of the dots fall below that line, indicating that white communities had much greater access to testing than black communities did, for example. And these were regions of St. Louis, Missouri. Again, not likely because of whiteness per se, but rather these other social determinants that accompany it. Next slide, please. Right. And so one of the interesting things that came out from the overall piece of data is this differentiation between exposure and risk of severe illness. And so what we're looking at in the top panel, where it says all tested patients in COVID, whether or not they were COVID-19 positive, then we have three rows: white, non-Hispanic, black, non-Hispanic, and Hispanic. And using the white non-Hispanic as the referent group, what we can see in the very far right side that's encapsulated in the red line is that when we think about who was testing positive for COVID-19, black non-Hispanics and Hispanic individuals were at 30 to 50% higher risk of testing positive from COVID-19. But when we think about, well, you've tested positive, are you more or less likely to be admitted to the hospital? And so there was no excess risk amongst black or Hispanics when you had the starting point of you've tested positive. Now are you more or less likely to be hospitalized? There was equal risk of hospitalization amongst the three racial groups. And then lastly, were you likely to experience a critical illness where you were in the ICU? And again, there's no risk differentiating by race. And so what really has distinguished the burden in white Americans versus those in minority Americans is exposures. And those exposures are largely driven through work, employment, housing, these social determinants. And there's no unique vulnerability by race, say genetically or something that's intrinsic to race, but rather it's through these correlated factors that we've been talking about. Next slide, please. So that's a repeat. That's actually where I wanted to have that slide. Next slide, please. All right. And so what can be done about it? And so I'm a policy person, and so I like to think about how state and federal government can help us address these social determinants and make health outcomes better for all of us, but also close disparity gaps amongst races, social classes, and so forth. And so the way that we often do this is through legislation. We call up our senators, our representatives, and ask them to do something to make situations better. Unfortunately, not all of us have an equal voice in this say, and that largely explains why the disparities are so difficult to address. And so if we want to think about, let's mobilize, let's get public opinion behind doing something like expanding unemployment insurance, doing greater subsidies for childcare, parental leave policy, something of that nature. And if we can just get the public behind us, then we can see legislative action. Unfortunately, that's not the way it appears to work based on the panel in the right. So this is looking at the gray bars represent situations in which this proportion of the population of the general public supported a particular policy behavior. The black line represents the probability that that particular policy was enacted into law. And so what we can see is when very few in the general public were supportive, down here in the 0 to 10% category, the 10 to 20% category, the gray columns, the probability of that legislation being passed was about 30%. You get all the way over on the right where 80% or more of the general public was in favor of this legislative action. The probability of passing remains 30%, right? And so there's pretty good evidence that general public opinion doesn't influence legislators' actions. If they don't, what does? Well, it turns out that it's economic elites, people who have money, resources, social standing, as well as interest groups, particularly those who are aligned with businesses, but also to a lesser extent, those who are aligned with social groups like AARP or something of that nature. And that's what the graphic on the left shows. The horizontal axis closer to us represents income, higher incomes moving left to right. The kind of axis that goes away from us represents whether there's little interest group support closest to us or the most interest group support away from us. And so when interest groups and the economic elites don't want something to pass, then there's only about a 10% chance of that policy or legislation passing. But when they're aligned, both supporting the policy, about 75% of the times that legislation passes, right? And so we're at a real disadvantage if we define ourselves, we as just average Joe Schmoes. And so the way to affect policy change is to group up. Well, one is to get rich. And so that would be one, but that's not an opportunity for everybody necessarily. The other way is to join a group and amplify your voice. And so through activities such as what we're seeing today, bringing together community coalitions and partnerships, those are essentially interest groups who are working collectively to achieve a common goal. Those groups are going to have more success in the policy sphere than any of us acting individually, because most of us don't fall into the rich category. And so thinking about the importance of our activities today is to coming together, sharing what we know, trying to decide on solutions, and then working hard to interact with our local, state, and national representatives to see the policies that we want enacted. Next slide, please.
Okay. And I'm so sorry, Dr. Gerald, because of time.
We're done, and I'm done. So great. So,
oh, okay.
so we reached the point together.
Okay. I could have just waited. Okay. Thank you so much. Alex?
Yes. Hi, sorry. So we still have one more speaker, Mr. Kumar, and then we will go back into general session. Dr. Amit Kumar is a health services researcher and trained in epidemiology. Dr. Kumar is an assistant professor on tenure track at College of Health and Human Services and associated with Center for Health Equity Research and adjunct faculty at Brown University. Dr. Kumar?
Thank you, Alex. So I'm going to present some of my own research, which I did last year. Can you hear me, Alex?
Yes, I can hear you.
Okay. So yeah, I'm going to present some of my own research, which I did with some of my colleagues from Brown University last year and this year, using publicly available data sets. And this was one of the first research which came out from Mexico, using Mexico public health data, as well as CMS data from US. So first, I will talk about the impact of COVID-19 epidemic in rural and urban areas in Mexico. So next slide. So here, as epidemiologists, we are getting again a lot of information and narratives in news and from political leaders that pandemic is over in Mexico or in the US. In US, we have got a 40% to 50% of vaccination of both doses, but in Mexico, with the daily, we are kind of seeing 2,000 to 3,000 new cases, and with the vaccination rate of almost 9% right now with the both dose, we cannot say the pandemic is over. And we have seen in some other countries, and I'm from India, in the month of February, the Prime Minister of India just declared that we won victory over the pandemic. And as a result after that, people get complacent, start going outside without masks. And with the poor vaccination rate again in India, we see it again, second wave of vaccine is destroying Indian healthcare system, and almost 4,000 deaths every day. And so I will still say pandemic is not over in Mexico with 10% of vaccination rate. So next slide, please. So Mexico is one of the countries in North America and Latin America hit hardest by COVID-19 last year, and large number of population in Mexico have higher prevalence of chronic diseases, living in poverty with limited access to healthcare services and poor health insurance. And we know that, like, Mexican population, obesity and diabetes have very prevalent, like almost 30% of the Mexican population have pre-diabetes or obesity. And these statistics are even higher among adults living in rural and border areas, which have, again, limited healthcare resources. And that's why they are more disposed to COVID-19 infection. And during last year, like, Mexico government did a good job in terms of testing, and mostly, and also didn't have enough hospital or ICU beds. So a lot of people died in the home, which we don't, again, have in official numbers. So whatever numbers we are seeing right now, we are seeing almost 200,000 deaths in Mexico in the last 1 year. We can add 60% on top of that number. And then same thing we are seeing in other developing countries or middle income countries. Next slide, please. So here I'm using the projection or data from Institute of Health Metrics and Evaluation. Seattle is a global health agency. So right now, still today, we have 220 deaths, and I'm on conservative side, I'm saying add 50% on this number. And daily deaths has been reported by the Ministry of Health from Mexico is 126. And in the Institute of Health Metrics and Evaluation, they do a lot of epidemiological data modeling, and they have projected, they were projected based on the number of deaths in the January, like almost 600,000 deaths by the September 1st, if that's like a little bit more on high side. But so far we are seeing less number, which is good. Next slide, please. Likewise, like, we are seeing in Baja California, the total number of deaths is 8,163, and daily deaths reported by state government is 2 or 3. And again, projected death was very high, 27,000 by September 1st. Next slide, please. And this is from the Sonora, total number of deaths. So far, we have 6,572, and daily deaths right now over the last 7 days, we are seeing 2 to 3, and projected death by September 1 was very high, around 15,000. Next slide, please. And here, this is data from Chihuahua. Total deaths so far, we have 6,871. Total deaths reported over the last 7 days. Every day was 9 to 10. And again, projected death by September 1st was 11,404. So still pandemic is not over. So what I'm going to present some of my study findings as I discuss the impact of COVID death in the urban and rural areas in older population. So first we examine the clinical and demographic characteristics for people diagnosed with COVID-19 by different age groups. And then we compared the COVID-19 cases and mortality in rural and urban communities in Mexico. Next slide, please. So again, last year the data was very limited and was not very much available and access to researchers. So we did what we can at that point of time. So we linked different publicly available data sets available from Mexican Ministry of Health, Department of Epidemiology. So we pulled the number of COVID cases and mortality from Department of Epidemiology. Then we pulled county level COVID-19 related mortality rates from census data and National Evaluation Council of Social Policy and Development. And from Department of Health information from Mexican Ministry of Health, we pulled a number of doctors, hospital beds, ICUs, and ventilators related information. And then we link all these data sets. Thank you. Next slide, please. And our outcome very well, where we calculated total number of COVID-19 cases and COVID-19 related mortality per 100,000 at the municipality level. And then we divided all municipalities in rural, semi-rural, semi-urban, and urban areas based on the number of population, which has been used in the previous research. And it's a valid way to define the rurality in Mexico. Next slide, please. And then the analysis, we described all those clinical and demographic characteristics by patient population, age group, and rural urban. And then we did zero inflated Poisson regression model to calculate the robust standard errors and calculate the marginal deaths by different municipality, rural, urban, semi-rural. Next slide, please. So here's the results. So you can see the patient characteristics of positive COVID-19 cases by different age groups. And as you can see in the 65 plus, we can almost have 13% of cases. In 15 to 64, which is a large age group, we see 85% of the cases. But in this table, we can see individuals living in a rural and semi-rural areas have a higher number of COVID cases compared to urban areas, especially in older population. Then also we see people with diabetes in older group have a higher prevalence of COVID cases. Same thing for obesity and other medical condition. Next slide, please. And here we have described about the types of care they are getting. So, of course, mostly people are getting ambulatory care, and almost 60% of the older population are hospitalized. But again, you can see not so many people are getting ICU or ventilators in older population or even in younger population also. So that was sad, and I think that is one of the reasons why we saw death in last year, because of lack of ICU, ventilators, and hospital beds. And same things are happening in Brazil and India right now, exactly. So next slide, please. So here we did some results, findings from the Poisson regression analysis, and we divided this number of COVID cases in overall population and mortality rates by rural, semi-rural, semi-urban, and urban areas. And here we can see rural areas and semi-rural areas have significant number of COVID cases and mortalities compared to semi-urban and urban areas. So it's statistically significant, very high. Next slide, please. And then we stratified our analysis by two age groups. One first table you see younger than 65, and then in the second table you see older than 65. And we see very similar pattern here, older adults are have higher mortality rate in rural and semi-rural areas, urban areas. Same thing for the younger population also. And we have compared for the other population level on demographic characteristics for this analysis. Next slide, please. So the future challenge is, again, we not seeing a very aggressive vaccination campaign in Mexico, just what we had in the US. We did a really good job here, but still, we had a 40% of vaccination. So I think the vaccination is a key right now in the Mexico. And it's also for the US is quite important, so if they have a surplus vaccine, they should start giving those vaccines to other developing and middle income countries. Right now, so what we are seeing right now, 60 to 70% vaccination rate in the developed world and 2 to 3% in developing world. So that's again a classical example of inequality. So this is a global pandemic, and I think we need a global effort to fight against it. And so that's the key for the vaccination. And I think US is doing administration started doing some good job sending some like 12 million doses of vaccine of Pfizer and Moderna to Mexico, but I think there more work need to be done in that area. So another challenge, like after 6 months, Mexico will have approximately 2 million cases of COVID-19 survivors with post-acute COVID-19 syndrome. Let's think about that also in a long term. And they will experience persistent symptoms of frailty, functional decline, depression, breathlessness, and other problems, and they will need post-acute care, which is entirely missing in Mexico, especially in rural and border areas. So that is another area which we can focus in future, how to develop a post-acute care system in the Mexico. Next slide, please. So here are some tentative solutions from a health service point of view. One is currently right now we can expedite the vaccination, which will have a higher impact and a good sustainability. The other two long-term objectives are build post-acute care infrastructure in Mexico, like inpatient rehab facilities, skilled nursing care, home health, and developing COVID clinic, which will also have a high impact on long-term basis. And the third one is to improve health awareness and education, targeting more social determinants of health factors and migrant workers, which will also have a higher impact on a long-term basis. Next slide, please. So that's about the Mexico research. And second, we did examine the racial disparity in COVID-related mortality by race and ethnicity in U.S. nursing home from June to December 2020. So we examined the high impact of high proportion of minority residents in nursing home on COVID-related mortality over the 30-week period. Why we did? Because nursing home is one of the kind of big ground of COVID in US. Almost 40% of deaths, COVID deaths, happen in the US nursing homes. And historically, nursing home have a history of disparity, both their basis of race and reason. And COVID was kind of opening this Pandora box when last year of demonstrating racial disparity in COVID-related cases and mortality. So we did this longitudinal study over the time period of last 30 weeks. And again, we'll use the CMS Medicare data from nursing home publicly utility files. And then we linked with the nursing home compare data set, long-term care data sets, and county level COVID cases and deaths. So we linked again, 3-4 different publicly available data sets, whatever available at that point of time. And our primary independent variable was proportion of minority residents and Hispanics living in nursing home and its association with mortality rate over the time. We published this paper again in Journal of American Director of JAMDA this April. So if somebody is interested, they can go and they can read the whole paper. Next slide, please. So without going too much detail in the methods and analysis, so here's the finding from that study. So it's very interesting, at the first, when we first analyzed the data of first 6 weeks, it was a different findings. We saw a significant disparity sort of in the nursing home death by race and ethnicity. So red line represent nursing home with high proportion of Hispanic. The green line represent nursing home with high proportion of whites. And the blue line represent nursing home with high proportion of blacks. So we can see it's first 6 weeks, we saw that the nursing home with blacks and Hispanic have higher mortality rates. Then after November or October, late or first week of November, we see a completely shift in the pattern, and we saw the nursing home with high number of white patients have a higher mortality rates. So that's very interesting. So we don't know what happened, but definitely one thing was clear that the COVID started moving from the urban areas to rural areas where they have a larger number of white population and with less health service resources. Next slide, please. So thank you, everyone. My study was supported by NIH, and here's my disclosure. If you have any questions, feel free to ask me, or you can go through those links to study the whole paper. Also, I'm sharing the link of the paper on the chat. What paper?
Amit, thank you very much. The other panels have wrapped up and are rejoining here. So we need to basically wrap up this panel. Is there anyone else scheduled to present? I don't have my agenda in front of me.
No, Dr. Trotter, no, all our panelists have presented already. Thank you.
That's fantastic. And Amy, is everyone coming back into this panel?
That's correct.
Okay. So I saw Amanda online and Michael online, so I think we can begin the wrap up. The panel we were in was fantastic. This sounded, as I caught the end of it, terrific. So it really is a very powerful set of presentations, and I want to thank everybody for their participation. Alex, do you have any wrap up for the panel?
No, Dr. Trotter, we can proceed. Thank you.
Thank you, Bob. Thank you, Alex, and thank you for all the panel members. I think that we could have hours of discussions in each one of them. Great participation and a lot of very good information that we can continue working with all of you. And thank you for the pleasure of your time in joining us as panel members. We're moving into the general session. I believe all the panels are completed, so we're going to move forward with the next speaker. And our next speaker is Mr. Russell Bennett. I believe he's online. Russ?
Yes, I'm here.
Okay, let me give you the pleasure of, let me introduce you. So Russell Bennett has worked in the healthcare sector at the border for more than 27 years. He was the founding executive director of the U.S.-Mexico Border Health Commission in the year 2000. That's when I had the pleasure to meet him. He founded Latino Health Solutions at United Healthcare and led that department for 14 years to help improve health equity and health awareness and literacy for Hispanic communities. Today, he speaks to us about the importance of health literacy during COVID-19 and the relationship between health literacy and social determinants of health, which is, he is an expert. So thank you, Russell, for joining us today. Thank you for waiting for our session. It will be our last session of the morning, so welcome again.
Thank you very much, Amanda, and thanks everyone for your patience. Can you hear me okay?
Yes.
Okay, great. Well, so the topic I'm going to address today is a call to action, health literacy and social determinants of health at the border. So first slide, please. Amy, could you click? There we go. Thank you so much. So, well, we've heard this morning from three outstanding panels on binational community outreach, on research, and on the educational component. So I'd like to bring it back to some of the things that we can all be aware of and can collaborate on, which include health literacy, the infodemic of misinformation, vaccine hesitancy, connecting health literacy, social determinants of health and health disparities, and continuing and growing cross-sector, and in this case, cross-border collaboration as well. So next slide, please. So health literacy as a social determinant of health has been argued by some experts because some of the social determinants, as we know, include homelessness and housing challenges, employment stability or lack of it, lack of access to safe and nutritious food, and lack of understanding of financial, insurance, and healthcare coverage issues. But I think importantly also, low or limited health literacy is a social determinant of health. As I said, experts still disagree on whether health literacy is an SDOH or if it's a mediating cause of other social determinants. But in Europe, following exhaustive analysis, investigators have concluded that comprehensive health literacy, as measured by the Health Literacy Survey in the EU, impacts health mostly as a direct determinant, and that only some of its impact takes place by moderation or mediation of other determinants of health. And Dr. Joe Gerald referred in panel 1 to this, showing how education is related to COVID-19 deaths. And people with poor health literacy also tend to be less responsive to traditional health education messages, less likely to use disease prevention services, and less able to successfully manage a chronic disease. Next slide, please. Robert Guerrero spoke about the problem of misinformation at the beginning of the pandemic. And I believe that misinformation has become a social determinant of health in a big way. There's been an extraordinary spread of misinformation during COVID-19, and we know that good information and good health go hand in hand. So unfortunately, along with the pandemic, we are living through an infodemic, a global overabundance of information that has made it difficult for the public to distinguish trustworthy health resources from phony experts, and it has created widespread confusion about real evidence-based safety measures. Now, part of our call to action is that all of us can take action to provide accurate information, but it will be most effective when it's provided through trustworthy sources. Healthcare professionals, community leaders, community health workers, promotoras, promotores, and family health coordinators. Now, what's important is that language matters. There's a new national poll that I note at the bottom of one of the slides that's called The Language of Vaccine Acceptance. And it reveals that there's an urgent need for political and health leaders to adjust their messaging to improve confidence in COVID-19 vaccines. And here at the border, it's even more important to break through barriers that we have culturally appropriate communications. Next slide, please. One of the things that has worried many of us is that there is COVID-19 vaccine hesitancy, even among health workers. The World Health Organization has identified vaccine hesitancy as a leading global health threat. And some of the healthcare workers, or many of them in polls at the end of last year, talked about safety and efficacy concerns, and that's why they don't want to get the vaccine. They have a preference for physiological immunity, but if you stop and think about that, that means instead of getting the vaccine, I'd like to become immune by getting ill. Now, if you haven't dealt with people that are ill and that are seriously ill, it may sound like an easy thing to get physiological immunity instead of the vaccine, but believe me, the vaccine is a much better alternative. There's also among healthcare workers and among the public in general, some distrust in government and health organizations and a need or a desire for autonomy and personal freedom. The other side of the coin, however, is that healthcare workers also have potentially powerful influence on patient vaccination decisions, and those healthcare workers that are vaccinated are more likely to recommend vaccination to others. So understanding and addressing healthcare workers' vaccination attitudes is crucial to promoting COVID-19 vaccine acceptance, and it can also provide important lessons for other infectious disease crises. A friend of mine said not too long ago that COVID has changed from an issue of numbers to an issue of names. We used to say there are so many thousand people in such a country, and now we say, I have 3 or 4 or 5 friends who have gotten ill, who have died from it. So it's turned from numbers to names. Next slide, please. So this article that I referred to a moment ago, it was a poll about the language of vaccine acceptance. And we talk about health literacy, but we probably need to also talk about vaccine literacy, because what we say matters. I mentioned that we need to adjust the messaging to improve confidence, but the poll identifies the language that will be most effective in reaching all people in the United States, especially those who are currently less likely to take a vaccine. And the poll identifies rural Americans, Republicans age 18 to 49, Black Americans 18 to 49, and women 18 to 49. Now, this is not a value judgment. It's simply what the poll said, but we need to change our vaccine lexicon to help bridge key differences and rally people across the country toward vaccine acceptance. You need to tailor your messages for specific audiences, explain the benefits of getting the vaccine, not just the consequences of not taking it. Talk about the people behind the vaccine, the scientists, the health and medical experts, not the science, the health, and the pharmaceutical companies. You need to avoid judgmental language when talking about or to people who are worried about taking a vaccine, and acknowledge their skepticism and offer to answer their questions. We know it's been said today many times that Black and Latinx Americans are more motivated than the general public by the potential to stop wearing masks, but Latinx Americans were the only group in this poll more motivated by the statement that taking the vaccine is the right thing to do than by getting the vaccine will keep your family and friends healthy and safe. Next slide, please. So how does health literacy or lack of it affect Hispanics? 41% of Latino adults lack basic health literacy, and about 65 or 66% are in the basic and below basic categories. Only 4% have the proficient health literacy necessary to make appropriate health decisions. And non-native English speakers are more likely to have low health literacy, and we have a very large population of non-native English speakers at the border. Immigrants are more likely to have difficulty navigating the US healthcare system, and linguistic and cultural barriers further compound the challenges. In addition to all of that, you have the fear factor where patients may be afraid to share their medical data. Next slide, please. So low health literacy, or LHL, it's not meant to be a diagnosis, but it's really a marker of a number of life circumstances, including limited access to education or access to poor quality education, limited English proficiency, and in some cases, learning differences, learning disabilities, and even cognitive impairment. But we do know that patients with LHL are more likely to have poor health, higher rates of chronic disease, and a nearly 2-fold higher mortality rate as compared to patients with adequate health literacy. Compared to those with adequate health literacy, persons with low health literacy are also more likely to experience disparities in health and healthcare access, to have lower rates of receiving screening and preventive services, including COVID screening, to exhibit patterns of utilization of care that reflect a greater degree of unmet needs, such as excess emergency room visits and hospitalizations, even when you control for comorbid conditions and health insurance status. And low health literacy individuals are more likely to have poorer knowledge of their disease processes, of their medication regimens, and exhibit worse medication adherence and inadequate skills and methods for managing their disease. It's also important to note that low health literacy has a negative effect on the communication between doctors and patients. So patients with low health literacy are more often speaking in a passive communication style. They're less likely to engage in shared decision-making, and they're more likely to report that they're not satisfied or empowered by their interactions with their physician. This is an important statistic. It's been estimated that low health literacy leads to excess health expenditures of more than $100 billion a year. Next slide, please. So I won't go into health disparities, but we do know, and this has been discussed in the panels today, that there are health disparities related to educational attainment, related to race and ethnicity, and related to ethnic and linguistic subgroups. And Dr. Kumar, among others, have been very eloquent in showing some of the data around this. But in all of these, there is a link between health literacy disparities and health disparities. So next slide, please. I saw an interesting article by Dr. Dean Schillinger of UCSF on the intersections between the social determinants of health, health literacy, and health disparities. And at the bottom of my slide, there's a link to his article. But what he shows is a novel conceptual framework for the pathways that connect SDOH, health literacy, and health disparities. On the right side of the chart, you see the healthcare pathways. On the left side of the chart, you see the public health pathways. But everything centers in this chart on health literacy, going from the social determinants of health through health literacy on both pathways and to the health outcomes and health disparities. So an interesting article if you want to follow up with that. Next slide, please. And how about health literacy in the pandemic? Well, we know, and it's been discussed, that Hispanics and African Americans are suffering disproportionately from the pandemic. But we also know that better information, when it's well understood, leads to better decisions and ultimately better health outcomes. We need to help people understand general health issues. We need to help them understand how to keep safe from contagion. And we need to help them buy into the actions that will keep them as a patient, their family, and society safe. But let's remember that although the pandemic and COVID-19 are top of mind right now, chronic diseases have not gone away. The Undersecretary of Health in Mexico a few months back talked about the fact that once the pandemic is controlled in Mexico, we need to refocus on diabetes, on hypertension, and other heart diseases. And of course, in both countries, that's true. And we also need to focus on others, such as oncology and neurology issues. And one thing that has come out very importantly, and it's been mentioned by Dr. Ramirez Wakamatsu, by Diana Gomez, and many of the other speakers, is the anxiety and mental health issues that are on the rise. So next slide, please. We know that the pandemic can affect all of us, even if we don't actually get COVID-19. The levels of stress, anxiety, and worry have increased among patients, as I mentioned, among healthcare professionals and across the workforce, even outside of healthcare during the pandemic. And then there's a question of double jeopardy. COVID-19 and behavioral health disparities for Black and Latino communities are very high. So the Regional Center for Border Health partnered with the Institute for Healthcare Advancement to prepare a short book based on health literacy best practices to help manage anxiety. In English, it's called How to Manage Your Anxiety During COVID-19, Practical Tips to Help You Be Confident During the Pandemic. And it's being published in both English and Spanish. Next slide, please. This is the Spanish version, Cómo Manejar la Ansiedad Durante COVID-19, consejos prácticos para ayudarle a sentirse seguro durante la pandemia. And the message here is ansiedad y COVID-19, todos hemos manejado momentos difíciles en nuestras vidas, pero al aprender más sobre la ansiedad y el estrés, también podemos manejar esto. There's a message there from Amanda Aguirre, and as I understand it, these books will be available at the RCBH and its different facilities in the next couple of weeks and in the month of June. Next slide, please. So what are some of the calls for action that we could all begin to look at? I believe that to combat misinformation, to improve health literacy, and to address social determinants of health, there needs to be more and continuing collaboration. We've heard a lot about some of the collaboration that's already going on, but we maybe need to raise it to the next level of collaboration between public health, healthcare organizations, community clinics, individual healthcare providers, community health workers and promotoras, and academic institutions on both sides of the US-Mexico border. And the next slide, please. Some action steps could be that healthcare organizations should strengthen their commitment to health literacy all across their operations, to leverage the therapeutic relationships they have with patients to promote and track progress in health literacy, and to identify appropriate teachable moments for addressing the misinformation, and to plan appropriate health literacy interventions for each of those teachable moments. And of course, healthcare organizations that manage community health centers should recognize the potential of those community health centers as key sites for promoting health literacy among the most vulnerable members of society and for combating misinformation. And you might even consider leveraging college students as agents of change and community educators. Now, healthcare professionals should build and enhance relationships with the communities they serve. They should make every effort to understand and respond to their patients' unique health-related knowledge, their beliefs, and their conditions of literacy. And they should reinforce their cross-sector collaborations with public health systems. And if you look at both healthcare organizations and individual providers, they should leverage the community relationships and leadership of promotoras and promotores and family care coordinators to improve health literacy and address vaccine hesitancy. Next slide, please. So this is my last slide, essentially, other than the resources. But I'd like to take just a brief look back because, as Amanda mentioned, 22 years ago, we started the US-Mexico Border Health Commission. And in October 2001, about 20 years ago, we issued the first annual report. And this graphic comes directly from that annual report. There were 4 primary recommendations that we made to the respective presidents and congresses of both the US and Mexico. And those were that we needed to invest to improve access to quality health care, to improve disease prevention and health education, to improve health workforce development and retention, and to improve public and private health infrastructure in order to help eliminate health disparities and attain the Healthy Border 2010 goals. Well, 20 years later, we now have the Healthy Border, or Healthy People rather, 2030 goals, and some of these actions are the same ones. So there's been much progress in the intervening years, but we still have many of the same goals to improve border health and to promote health and well-being for the residents of the border area and eliminate barriers to health improvement. So those are the calls to action. And I think this would be the last slide, Amy. These are some of the resources that I used to put this talk together for you. And when it's distributed, you'll have the links to all of these in case you want to follow further. So thank you very much, Dr. Trotter, Ms. Aguirre, for the opportunity to address the group. Thank you.
Thank you, Russell. Incredible presentation again, pretty much summarizing a lot of the discussions and the barriers and challenges that all of us in healthcare have faced, and at the same time, the innovative solutions that you spoke about, working with promotores de salud, and also, raising the level of education and increasing the access to care and of literacy among our constituents or among our residents, that will make a lot of difference in health literacy. So thank you for bringing that topic to the light and to share with us in today's keynote speaker. And with this, I know we're very close to concluding our session. Thank you again to all the panel members, our keynote speakers, our sponsors, with great gratitude, especially with the folks that work with us on all the logistics. Of course, my good friend, Dr. Robert Trotter, Dr. Sabat, Dr. Linda Ransel, Amy Gallett, Marcella Levier, Chris Erb, and Chris Martin and the telemedicine program, Maria Jose, my assistant here in Somerton, and the many technicians that work today to make our video conferencing to work. We know that these times are difficult and hard sometimes, and in rural communities we have to juggle as many challenges that we face, and certainly the video communication is one of them. But I think that with your help and your presentations, make this whole worthwhile and incredible work. I'm going to pass it down to Mike. Mike, do we have final remarks and final logistics for the participants? I do want to thank one more, also our translators, who I cannot imagine the work translating all the sessions. They were incredible. And Ms. Fierros, Mr. Salón, and Mrs. Noriega, thank you. Muchas gracias por sus traducciones. And our partners, los amigos de México, gracias por estar con nosotros en esta mañana, en estas sesiones. Mike, it's all yours. Thank you all.
Thank you. Thank you, Amanda. I want to thank everyone also for attending, and hope that you'll participate in our future sessions. It's clear that the pandemic has posed significant problems for all jurisdictions in our region on both sides of the border. And sessions such as this one really help us to understand the nature of the problems that we're experiencing, their impact on our health, and how we might better address them going forward. Lastly, again, I want to remind everyone, we will provide certificates, CME credit. You'll be receiving those via email. And as you sign out today, there is an evaluation form. I hope you complete it. If you don't have time now, we'll follow up with an email so that you get a copy of the evaluation form and complete it when you have more time. Lastly, as you know, the panel sessions have been recorded, and the resulting videos will be edited and available through the conference registration page in about a week. Apart from that, I want to thank you all and have a great day.
Thank you all.
Fantastic job, everyone. Thanks.